Yep, yep. You're getting that? Is it too quiet? A little bit too quiet, right? Okay.
Good morning. Can you hear me? Perfect. Thank you. So, just a few housekeeping items to remember this morning. In person attendees need to sign the sign in sheet for today's session if you've not already done so. A reminder that all virtual participants are set to mute. If you have a question, please type it in the Q&A box and we'll have the speaker address it at the end of the session if time permits. If not, we will collect answers from the speaker and distribute the response to all registrants. All presentations will be available to view on demand online for 1 month following the conference. Attestation forms needed to claim CME credit may be completed by the attendees today at the close of the conference. These forms will be distributed to in-person attendees and are available online for virtual attendees. PDFs of today's presentations are available at LMU-live.com. Disclosures for all speakers are available for inspection at the Office of LMU-DCOM, Director of Alumni Services. This morning, our first presentation will be dermatologic conditions in the geriatric patient, presented by Dr. Mandy Al-Hajj. Dr. Mandy Al-Hajj received her osteopathic medical degree at LMU-DCOM. She then completed her dermatology residency training at University Hospitals, Case Western Reserve University in Cleveland, Ohio, where she served as academic chief in her final year. She is now a dermatologist providing care to our veterans at Louis Stokes Cleveland Medical Center. Dr. Al-Hajj has no financial relationships to disclose. Please help me welcome Dr. Al-Hajj.
Morning, everyone, and happy Father's Day to any dads out there. Thank you for being here this early in the morning for this talk. I wanted to put together really geared at things that I see very commonly as new patients, things that are a lot of the time, parts of normal aging skin, and I just want to make sure that you guys are first line of defense before coming to dermatology, especially with these long wait times to come in, have the tools to really provide the first steps to help these patients with their quality of life. So I have no financial disclosures. Some brands may come up just in passing just because of the nature of some of the discussion as far as soaps and things like that. But the goal today is really to identify common skin changes that we see as part of normal outcomes of aging skin, recognize when patients really do require referral to dermatology, and how to perform that initial workup, identify just the characteristics of what's normal and what's not, and when to appropriately refer. So aging skin, we know there are going to be changes at every layer of the skin and all of the supportive tissue surrounding. So our epidermis will decrease in thickness with time. That's just the nature of it. Lipids will decrease, and the structure of the epidermis also decreases, resulting in barrier dysfunction. The dermis will have decreased collagen synthesis, and then the quality of the collagen that's actually being synthesized will decrease as well. And depending on the degree of sun exposure over time, there will be solar elastosis, which will also change the quality of the skin. Our sebaceous glands will start to increase in size, and even though they're increasing in size, they may not necessarily increase in output of the oil secretion. So you may see these in your patients and wonder, why are there all of these kind of yellow-pink bumps on the face? They tend to have a little central dell or depression in the center. They can be very commonly confused with early basal cell carcinomas, which we'll talk about later. But I wanted to have that demonstrated here. So these guys here, very common on the face. But you can also see them on the chest, anywhere you have oil-rich skin. So subcutaneous fat will also redistribute, and that subcutaneous fat will start to thin as well, and we can see those results later in some other areas. So young skin on the left and aged skin on the right. Oops. You can appreciate the collagen is far more dense here, and then lots more loose tissue in between our collagen bundles on the left. So other things that will occur our immune response to infection will reduce because our surveying dendritic cells are going to reduce in the epidermis, and so our patients are going to have increased sensitivity to infections, but also other inflammatory conditions. Our skin microbiome is really a hot topic right now in dermatology, which we're studying very much so really in a lot of our chronic conditions like psoriasis, its effect, seborrheic dermatitis, and other things, but the microbiome will also be altered. And then functional changes, your patients will start to experience sensory alterations. We don't fully understand exactly all of the things that are occurring as far as a sensory component, but that is something we do see very often in clinic. The anatomy of the changing face, our bone structure is changing constantly. So we're going to see skeletal changes such as lateral translation of the orbits, protrusion of the glabella, so more prominent brows, expansion of the supraorbital ridge, increase in depth and lateral expansion of the cheeks, and then increased length, width, and vertical dimensions of the nose. Why is this important? And chin prominence, because those changes will lead to sunken eyes and some of the outcomes that folks will come to you maybe concerned about. Oh, my face is changing, it's asymmetric, something's going on. What can you do for me? Can you provide me a cream? Oftentimes, these things are not going to be helped with a cream or a facial or a laser. A lot of these things require surgery or other cosmetic treatments. The fat pads are going to redistribute and start shifting downwards. And when that occurs, you can have the prominent lower lid, and there is really nothing you can do for this other than plastic surgery. So if someone comes to you about something with the lower eyelid, with that prominent fat pad, that's someone who needs to see oculoplastic surgery. Other things that we're going to see in the skin are going to be our intrinsic skin changes that we see visually, but also the extrinsic things. So intrinsic in our sun-protected sites, we're going to see maybe fine lines, dry skin, and then normal benign neoplasias, which we'll discuss later. And then extrinsically, we're going to see photoaging. Photoaging is what you're seeing in this patient here on the screen. You're seeing thicker skin, you're seeing more cobbled, deep lines. And these are the folks that you worry about malignant neoplasias developing within the areas of the face. This person in particular, you can really appreciate all throughout, but you can also see that kind of downward progression, that sunken down look. UVA rays are going to be the cause of our photoaging appearance, but our UVB rays are going to be the cause really of burns and most of the neoplasms that we see malignant-wise. So it's really important to educate your patients about getting a broad spectrum sunscreen, and we'll talk about that more as well. So solar elastosis, we talked about that. Solar elastosis is really something we see under a microscope, but this is how it can appear on the skin. So your patients who have these findings have this like yellow, cobbled, rough appearance in their sun-exposed sites. Those are folks who have had significant sun exposure and sun damage. So those are people you really want to make sure you're asking them, do you have any skin lesions of concern? Is anything changing? Do these people have other features that would be concerning for neoplasias that requires baseline full body skin exam by a dermatologist? So part of our epidermal and dermal changes can result in things like this, where we have increased skin fragility and actinic purpura. Actinic purpura is this over here. I receive so many consults because of this finding, and patients are not really sure how they can correct that. Some may or may not be on anticoagulant therapy. Regardless, this is a part of normal aging skin. Our skin is going to become more fragile. As our skin thins, we're going to have more superficial dermal vessels that are more prone to trauma. When this occurs, there is actually over-the-counter therapy that you can recommend to your patients that can be helpful, and that is here. So arnica gel or cream, it is something that is utilized in the plastic surgery realm. So you can get it over the counter. Not all stores have it available, but you can get it on Amazon, online. You apply it twice daily to the affected area until the bruise resolves. It's not going to resolve the bruise very quickly, but you can see significant reduction in the appearance within the first 2 days. I've tested it out myself, and it actually does work pretty well regardless of the age of the bruise. And you can actually use it preventatively. So if a patient has an upcoming event, they bump their arm, they know that they're going to have something there, they can go ahead and start applying twice daily. At least you can apply more than that. Other signs of sun damage are going to be poikiloderma. Poikiloderma is a word that we use to describe a combination of telangiectasia, so redness, hypopigmentation, and hyperpigmentation tends to be along the neck and face region, can also be on the chest. Sometimes in dermatology we'll describe things as poikilodermitis, like in cutaneous lymphomas, but not a true poikiloderma related to sun exposure. Other signs that your patients had a lot of sun damage and sun exposure are these weathering nodules that we see on the helicis. So if you see that, that person's probably had lots of burns and sun exposure in their lifetime. And then another one that you might see a lot here, especially with increased use of tobacco products, smoking cigarettes, is going to be Favre Recouchot, which is the solar elastosis on the face, and then you have dilated comedones prominent along the cheeks and periorbital region. Really, your only treatments are going to be smoking cessation, sun protection, and you can add in a topical vitamin A, so tretinoin. When you're starting a tretinoin, it's really important to start with something that's going to be lower strength so that you have room to increase. I would do a tretinoin 0.025% cream, so it's and really educating your patients that if they're going to use this, they should only use it twice a week and slowly increase by 1 night per week as tolerated, as this will increase sensitivity and cause irritation, especially in the periorbital region. And then this photo is really there to demonstrate how left-sided photo damage is very common in the US in particular, because we drive with our face exposed to the mainly because a lot of patients will tell you, oh, I don't wear sunscreen, I only wear it when I go outside. Even if you're driving, if you sit by a window at work, your windows only really protect you from UVB rays. They do not protect you from UVA, so you really do need to have a sunscreen on even in the car. So other consequences of these changes, which you will see, this is very common to varying degrees, we're going to have various dermatidities that we see as a result of aging skin. So xerosis, just plain old dry skin. You can see ichthyosis vulgaris, which is kind of on that same spectrum. Atopic dermatitis, contact dermatitis, whether that's irritant or allergic contact, and then different infections. So xerosis, just plain old dry skin. This is something that you will see in your aging population. Because of the changes that we talked about previously. Pre-existing conditions can definitely increase that risk, so having had radiation for any reason, having end-stage renal disease, having underlying conditions like HIV and malignancy, that all can contribute. Some medications can reduce that, and by some I mean lots and lots of medications can do that, so just be mindful of that. Getting a good skincare regimen is going to be really the foundation of everything I talk about today. So really getting a good handout or having just your spiel that you give to your patients who have the dry skin or itch or any kind of rash, that's going to be really important. And this applies to even your pediatric patients. This applies to everyone. A bad skincare routine with harsh soaps, long showers, hot water, that's all going to make their situation worse. And oftentimes, just changing that alone can make a significant difference in this patient's quality of life. So what is a gentle skincare routine? You want to use a gentle soap when in the bath or shower. What is a gentle soap? Something that says for sensitive skin on the bottle or on the box for the bar of soap. Something that's fragrance-free, free and clear, your buzzwords for gentle skin. Things that smell really good and make the patient feel really clean oftentimes are the harshest and the worst for them. I will just mention the names that are very common, just because that is the truth, and that is Irish Spring, very harsh, and so is Dial soap. A lot of folks think that things that are for sensitive skin like Dove are not antimicrobial, and that is false. They also are antimicrobial, so you might get pushback from your patients. Oh, I don't use that because it's not antimicrobial. That is not true. So fragrance-free for sensitive skin. You want to limit showers to 10 minutes or less. You want to use lukewarm water, not hot water, and you want to, once they're out of the shower, pat dry and then moisturize. Using a cream or ointment for those who have true dry skin is most important. Using a lotion is less helpful, mainly because lotions are water-based. They just are not going to moisturize really dry skin well. So getting a cream would be number one for someone who doesn't like that texture of an ointment, like Aquaphor or Vaseline, but getting a good cream, something that's in a tub. If it pumps, it's probably not going to. That's the basics for a good gentle skincare routine and your foundation for really everything. And I know this is a geriatric talk, but I just want to do a plug for your pediatric patients, especially your infants, toddlers who are coming in with baseline eczema. This is foundational to everything, and it's really important that they get daily baths. A lot of folks think, oh, they're dry, I don't want to do daily baths for them, but doing a daily bath helps kind of get that barrier under control and gives an opportunity for really good moisturization. For those folks with every diaper change who have active eczema, every diaper change they need to get moisturized. Slippery wet babies, good skin. So yeah, atopic dermatitis. Atopic dermatitis is being increasingly recognized in our geriatric patients, and the mechanism is slightly different, actually. We're learning and we're studying that further. But when you think of atopic dermatitis, you want to think of red, itchy papules, patches. Sometimes they can be coin-shaped, nummular. Sometimes they're going to be in the classic areas, like in the flexural sites. Oftentimes we see it in the legs and trunk area. Your eczema, so atopic dermatitis, is going to come in different stages. In the acute stage, it tends to be far more inflammatory, can be really edematous. They can have blisters at that point in time. As it ages, it's going to become more dry patches, very itchy, an itch that they really cannot seem to scratch. They just keep on scratching. It's that itchy. In the early stages, it can be a little bit more of a burning itch, especially when we talk about our contact dermatitis. Chronic gets thicker, and I'm going to demonstrate some photos. So I really wanted to show you really the differences of what erythema can look like in light and darker skin. So both of these patients have erythema, active erythema, and atopic dermatitis in their antecubital fossa. And then with time, with rubbing, with just the natural progression of atopic dermatitis, these areas get thicker. The reason this is important is atopic dermatitis, if it's left untreated, can really start to look a lot like psoriasis. And it can be really challenging even for a dermatologist who's seeing a patient for the first time to say, is this chronic atopic dermatitis or is this psoriasis? And we oftentimes biopsy these folks. And then far more generalized, this person is covered all over here with atopic dermatitis, and you can see it on the other patient as well. These folks, someone like this would be someone I would be very quick to put on a systemic agent like dupilumab, Dupixent. So management, gentle skincare routine plus topical steroids. In general, when you're thinking of your topical steroid selection, I oftentimes, so for these folks here, the thicker the patch, the stronger the potency, regardless of the location on the body, except for face and genitals. Face and genitals, I really don't want to go above hydrocortisone 2.5% or decenide. Anything above that is really concerning unless they have a really robust inflammatory response. I might do maybe 2 weeks of triamcinolone and do a quick transition to something lower potency. And if it's something I suspect is going to be very chronic, then add in a steroid-sparing agent like tacrolimus or pimecrolimus ointment. Which can be really hard to get approved, so that's just something to keep in mind. You have to have appropriate documentation that they've failed or that they're going to require this chronic treatment. Other things to get in on the regimen to just provide them some relief and to get them to not use their steroids more than twice a day is add in a good anti-itch lotion like Pramoxine. They can get that over the counter, but I believe you can also prescribe it. And if you keep it in the fridge for the cooling effect, any cooling effect is going to help with itch significantly. Contact dermatitis is a whole other animal, and the most common contact dermatitis is irritant dermatitis, hands down. A true allergic contact dermatitis is significantly less common. So that's just to let you know that most of these folks that we get in, we don't do patch testing for unless they really are not responding to conventional therapies. As far as irritant contact dermatitis, I bring this up because water is the #1 irritant to the skin. So your folks who work in a healthcare setting or work somewhere where they require to hand washing frequently, these are your folks that are going to have really severe hand dermatitis. So educating them that yes, you really only want to wash your hands when there is physical soiling. Otherwise, use a hand sanitizer. Every time you hand wash, moisturize. If you consider that our skin is actually very acidic at baseline, you're adding in water every time you wash your hands, and then you are using a basic soap, you are significantly altering your just normal baseline skin. So every time you wash your hands, you're doing that. So it's really critical to moisturize after you wash your hands. Really with every hand washing, especially for our folks with dermatitis. So these are some things that you can ask about, so things that you probably already ask about. Are they using different products, new products, nail things like manicures, gel? We see a lot of acrylic contact dermatitis. Your folks who have an acrylic contact dermatitis tend to touch their eyes, so they would have a rash around their eyes as well, but that's more complex, and we will leave that be for now. So management for a contact dermatitis would be the education about hand washing, moisturizing, doing your gentle skincare routine, and then adding in a topical steroid. If you suspect that there's a clear irritant or clear contact allergen suspected, have them avoid it before you send them to derm. And just having a good list before you refer is really helpful to us, because oftentimes in dermatology practices, they have their own EMR. They may not have access to whatever EMR you're using. So sending the patient with a full med list is incredibly helpful to us so that we can get the right culprit. Yeah, so derm referral if not resolving. Stasis dermatitis is another one that we see very commonly, often confused with bilateral cellulitis. Very chronic, it will progress. And this is what it looks like in its really severe stages. In early stages, it's not going to have that thick cobbled appearance, but you will see more of a sharp demarcation, tends to be bilateral. It can be unilateral in folks who have had surgery around the knee or the hip, or had lymph node removal because of that edema that's built up. So stasis dermatitis really is the result of venous insufficiency primarily, and that edema building up in the skin is pro-inflammatory. So getting compression stockings for these folks, leg elevation, and then really liberal moisturization is going to help them. So this is what it looks like in more darkly pigmented skin. And then counseling again. So it's really important that these patients understand that this is chronic and progressive. A lot of folks get frustrated. Why is this not getting better? Why am I not being cured? I keep getting infections because my skin barrier is altered. So really getting that stasis derm under control can help prevent true infection, true cellulitis from developing. I was going to say something else, but I forgot. But leg elevation, moisturization. For really thick scale that's developing in these patients, you can add in a keratolytic, something like ammonium lactate cream, urea cream, that can really help soften that scale. I just remembered. So these folks with stasis dermatitis have an increased risk of developing true allergic contact dermatitis from the application of creams. So it's really important to prevent the flares of the inflammatory rash. So really pushing for that compression. These folks have a significantly increased risk of a true allergic contact. And then subderm, you will see this all the time. It's very common. We see it across all ages, but especially in our older patients, especially if they have immunosuppression like diabetes. We see it a lot in our Parkinson's patients, post-stroke patients, and it's going to be in our sebum-rich skin, so center of the face, behind the ears, scalp, chest, upper back, very common. If left untreated, it can look really inflamed, really thick, and look a lot like contact dermatitis and psoriasis. So getting it under control early is really helpful. It is the result of malassezia overgrowth, so we really need an antifungal for treatment. And this is what it looks like when pretty severe in typical location. And this is what it can look like in more darkly pigmented skin. A lot more subtle, tends to be more hyperpigmented than red in appearance. And you'll find that erythema or inflammation in more darkly pigmented skin across the board is going to have more of a purple, brown color, just so you're aware. And then management for this is really dependent on how inflammatory it is and what's going to be cost effective for the patient. So some people will just go with Head and Shoulders, but the most important thing for any of these shampoos is to educate the patients that this needs to sit on their skin for a minimum of 5 minutes or it will do nothing. Using Head and Shoulders and then rinsing it off right away is not going to be helpful. You need to put the Head and Shoulders in there, let it sit for 5 to 10 minutes before you rinse. Same thing with ketoconazole shampoo. For someone who is more scale predominant, the salicylic acid shampoos can sting on application, so you want to make sure they're putting it on and leaving it on for at least 3 to 5 minutes before they rinse. And combining some of these elements can be really helpful. Selsun Blue is also a good one, or the selenium sulfide shampoos, and you can add in topical steroids, especially if it's itch predominant. Something like a fluocinolone oil for someone who has more curly hair type, and then a foam or a solution for other folks who have lighter or finer hair. Drug reactions are far too complicated and a whole talk in and of themselves, but history is the most important thing. Most common things that we see that cause a rash from a drug are going to be your anti-epileptics, antibiotics, and heart medications and statins. So if you had recently changed a dose, someone can be on something for years and years and years, but a dose change can be enough to cause a rash. Your beta blockers are very common, your statins are very common, and things like Lasix are very common. So things to keep in mind. If you have a suspicion that it's a medication, take them off of it, switch the class and see if the rash resolves. But these are folks that would benefit from a dermatology evaluation with a full med list. And then skin infections are going to be seen, whether that's bacteria, with staph being most common, viral with HSV, VZV being more common, and fungal infections like your typical dermatophyte infections like tinea curis, tinea pedis corporis, or candida infections. Those are all going to be common regardless of whether or not the patient is immunosuppressed, that you can see that, but as long as that skin barrier is altered, you're going to see this. Your atopic derms, you're going to see this in them if it's not well treated. So it's really important to get that good, gentle skincare routine on for them. And then consequences of really outside in. So this is an outside job, they're scratching. The clues for that are going to be that thickening appearance. They get more prominence of the lines. They're going to have this classic appearance. Oops. I turned something off, pressed the wrong button. There we go. So this thickening, very common around the ankles, on the lateral and dorsal aspects of the ankles. You can also see it on elbows, on the sides of knees. So asking, do you rest your elbow a lot, or do you cross your legs a lot? That can be a clue. You can see it on the lateral aspect of the knee, and then the lateral aspect of the lower leg is very common. But they'll scratch, 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 and that's just the normal skin response to protect itself from that constant trigger from your nails. Other things you can see are nodules. So other response, scar-like bumps that pop up in areas that are being scratched. We see it a lot in folks who have really uncontrolled dry skin or on a whole bunch of medications, and it's usually in areas that the patient can arms, shoulders, the upper back, and their thighs. Very, very common. There are new systemic agents if we can't control it with topical and intralesional steroids that are systemic, that have recently been approved, that we're also using for eczema, like dupilumab. And then autoexematization. I wanted to make sure we spent a good amount of time talking about autoexematization because you will see this. So autoexematization is the concept of you have inflammation in one part of the body. Your immune system is active because of that inflammation, and as a result of that inflammation, you start to develop rash in other places. That's autoexematization, or the id reaction. This is most commonly seen in folks who have baseline stasis dermatitis that's uncontrolled, athlete's foot that's uncontrolled, or they have eczema somewhere else. Those are the top three. But other things can also predispose. So by controlling those underlying conditions, the rash that's now really spread everywhere will also resolve. So it's really important that we're educating our patients that these are chronic conditions and that you're maintaining those treatments even after the rash has resolved. Very, very common. So pruritus without a primary rash is also something that we could do an entire talk on its own. And I get a lot of patients referred for pruritus without rash, but we see this primarily in folks with underlying conditions. So renal disease is one of the top ones, liver disease is another. But the most important thing from a primary care perspective that can really help us kind of pinpoint the area and rule out other underlying issues would be doing a baseline CBC with differential and see, does this patient have an anemia that could be explaining their itch? Do they have a iron deficiency anemia, vitamin D deficiency? Those are really our top things. Thyroid dysfunction is another one that can really affect folks and result in itch without rash. And then, is the rash truly generalized, or is it localized to one region? Is it only on their right arm, bilateral arms? Is it a specific dermatome? Could it be explained by nerve compression? So you might have folks come in with more hive-like rash. So just things to consider. So itch without rash is totally appropriate to send to dermatology for workup. So if you see something like this, this can be very commonly confused with tinea or psoriasis, but your clue that this is something more ominous, even if it's just localized, is that it's in sun-spared sites and it has a poikilodermatous look. It has that patchy red, it's not very scaly actually, and it's in sun-spared sites. So we often see cutaneous lymphomas on the thigh, on the buttock, in hidden areas. But it can occur in more sun-exposed sites, but tends not to be. And a lot of our treatments for those with patch stage is narrowband UVB therapy. So we know that the UV rays can help reduce that inflammation in the skin, so can explain why you're seeing it more in the sun-protected sites. If you see something like this, so blistering in the oral mucosa, blistering anywhere else, sometimes our folks, like we talked about earlier, they don't have a blister, so really having an itch with kind of an edematous papule can be a sign that a blister is coming. Our blisters can develop just from having inflammation in the skin. You might see blisters develop just from having edema in the lower extremity. So our stasis derm folks, they can even get blisters on the legs. But if you're seeing significant blistering, that is a high-risk situation. These patients are going to require chronic immunosuppression. You really need to get them to dermatology. I don't know what the wait times are like out here in East Tennessee, but I can only imagine it's really challenging to get folks to dermatology. So getting a good skincare routine for them, getting them that gentle skincare, but someone who has blistering like this is going to require significant wound care. So that person would require an ointment. That person needs a good petrolatum jelly on them constantly, because that's a significant water loss that they're going to get with blisters like this as they slough. Key points, I know we talked about a lot of things. Aging skin's going to undergo a lot of changes. A lot of the things you just saw are just, they're going to happen to varying degrees. So being prepared, ready with a guideline for them, good counseling for them, letting them know, hey, like this is totally normal. You're gonna be dry, it's gonna be itchy, and we're gonna have to keep going after this for a long time, but these are things that can make you comfortable. We know that there are cosmetic changes. That's neither here nor there, and that's something that they can take care of with a cosmetic dermatologist or oculoplastics, but really getting that good skin barrier, watching out for those immunologic changes that are occurring in the skin, that's really, really important. And this get an educational handout. If you can do anything just to save yourself time in clinic, just have a good handout that has all of this information for them. That way you can just give it out and you know that they have that. All right, neoplastic processes. So neoplasias can be benign or malignant, and I'm gonna first talk about the benign things, which are very, very common. So we will see this in all aging skin regardless of phototype. So light skin, dark skin, you can get seborrheic keratoses. They are incredibly common and a very common thing that we have as a new consult, mainly because the patients hate the appearance of them. And if you can identify them, know what they are, you can take care of that too for them, get some bonus points from the patient for freezing it off. Lentiginous and angiomas are the others. So here are your seborrheic keratoses. You can see they can be flatter, tanner, flesh-colored. They can get darker, crusty. So here you go. Here's a variety of them. When they get inflamed, they can be a little trickier because they get a little bit less crusty. They start to be pinker in appearance, and they can be suspicious and look maybe more like a non-melanoma skin cancer. In those settings, it can be tricky. So it would be worth shaving something like that off just to confirm, and then you're also therapeutically removing that irritated spot. Lentiginous, on the other hand, are a direct outcome of sun damage. So seeing spots like this on the face, on the scalp, on the extremities is going to be expected. And looking at those and being able to contrast that to something that's more concerning, so darker, more patchy, irregular, like a lentigo maligna. Lentigo maligna can be tricky because it can be mixed in with your other lentiginous, but really recognizing that patchiness, that irregularity, just something doesn't feel right. It's that ugly duckling in this whole area is critical, trusting your gut with that and getting them referred out. Angiomas are also very common. They can be very teeny tiny, and then they will grow with time. Start to see them after the age of 18, and they'll just keep on coming. They will bleed pretty heavily. You can see something within the family of angiomas like this called angiokeratomas that tend to occur in the genital area. So you might have some patients who are really concerned about that. They tend to be more purple, darker in color, also harmless, but they are treatable with cauterization, cryotherapy if needed, if they're starting to bleed and become bothersome. And then actinic keratoses. Actinic keratoses are a direct result of photo damage. So if you start to see more pink macules in sun-exposed sites with a gritty scale, your clue is really there from that texture. So we do a lot of touching for exams for this. You'll see it more commonly in your gentlemen on the scalp, forehead, ears are very common sites. But if you see someone with significant photo damage where they're developing these actinic keratoses, this is someone who needs to be established with dermatology, baseline exam. If they have that much damage that they're developing actinic keratoses, they are very high risk for developing other skin cancers. Management is cryotherapy. Sometimes we'll do field treatment with things like Effudex and photodynamic therapy. That's really beneficial kind of as more of a once a year type treatment because this photo damage exists, these folks are at high risk for continuing to develop more of these actinic keratoses over time, regardless of whether we're freezing them or not. And then this is what it can look like. So it can affect the lower lip very commonly. We call that actinic cheilitis. And then the gentleman on the cheeks, that can be tricky. So that's another trick. So actinic keratoses in that seborrheic distribution can be very easily confused with seborrheic dermatitis. And what I often do in clinic for folks who come in with like an appearance like this gentleman, I will do ketoconazole cream twice daily for a month before I bring them back and make sure that we've cleared any seborrheic dermatitis component first so I can better understand, is this person going to benefit from field treatment, because that would be my first inclination for that person, or after I treat that sebderm, can I freeze with liquid nitrogen and do more directed therapy that way. So that's something you could do in clinic, is just preemptively give them a ketoconazole cream for a month and then see if that helps, and that way you can focus in if you have liquid nitrogen in office. So we know skin cancer is the most common type of cancer in the United States. Basal cells are number 1, squamous cells are number 2, followed by melanoma. It can affect anyone regardless of skin color. So that's really important. Any lesion of concern, regardless, should be investigated. And if there's any question, if you're like, it just doesn't fit right, but I'm not comfortable, just send to derm. There's no harm in sending. Skin cancer surveillance, you guys are our first line of defense. What you see is so important for us, because really we're not going to see them unless you send them, or if they have the means to go seek it out themselves. So you guys are number 1. So really looking for those things, doing a quick scan, that ugly duckling sign, looking for that thing that's asymmetric, looking for that thing that's irregular, letting them know to check themselves. They know their body better than anybody else. They're going to know when something's not right, and they need to tell you. Non-melanoma skin cancers are going to act like pimples that don't go away, a spot that doesn't heal after a month. Those things really require further investigation, and it's totally appropriate to send to dermatology. So full body skin checks, identify any potential skin problems you're doing all of that. But getting that baseline, getting a good gentle skincare routine, figuring out, okay, are we in a sebderm world or are we more in an actinic world? That can be really helpful. And then biopsies should be performed early on, and we can talk about that more. I don't know how much biopsying you're doing in office, but that getting a good training on how to do that, when to do a shave versus when to do a punch biopsy can be really important depending on what we're assessing. In general, if you are doing biopsies in office, if there is a lesion of concern, getting a photo early on, getting early measurements with your referral, that is so important. Getting a photo if you're going to do a biopsy is so important. We get so many patients sometimes with a referral, they got a biopsy, it's a skin cancer, but they got the biopsy 5 months ago because it took forever to get them in, and now we don't really know where exactly where was the biopsy. So getting that photo is really, really important for the patient to get the right treatment in the right location. Getting appropriate depth depending on biopsy technique. If you have a lesion that your concern might be a melanoma or something else, please do a lymph node exam if it's larger than 2 centimeters. That can be really important as far as staging. If there's a palpable node, that node needs to be sampled, so that's really critical. So in general, our diagnostics, I'm not going to go through the bullets here, but what I want you to take away from this is that if it's a rash, do a punch biopsy. If it's a lesion, as long as it's less than 1.5 centimeters, a shave biopsy is appropriate. You're never going to be wrong for shaving the entire thing off, even if it's benign. Whatever your tools are, whether you're using a 15 blade or a derma blade, getting that whole thing off is critical. If you suspect a melanoma, make sure whatever you do as far as sampling, you're getting a 1 to 2 millimeter margin around it, doing an excisional. If it's too large to do an excisional, then you can do a partial, but that patient may be upstaged if it's truly a melanoma. So those are the critical points that I want you to take away as far as the method you use for the biopsy is very important. And I wanted to give this. So this is a free app you can download, which can really help you know how to manage certain things. So let's say you did do a biopsy and it came in as a squamous cell carcinoma, and you're like, should I do Mohs for this? Is this something I can treat in office? This will help guide you what's Mohs appropriate. Early skin cancers can be treated with therapies like electrodesiccation and curettage, which can be done in office, or for our older patients who maybe cannot tolerate some of these more invasive procedures, you can do a treatment called deep cryotherapy, which you do 3 cycles of liquid nitrogen application to the affected site with a margin. So that's something we do for some of our older patients, or even field treatment, photodynamic therapy, those things can be utilized as well. So not all skin cancers necessarily are going to be treated with surgery, even though it's, yes, gold standard, but it may not be the right treatment for your patient if they're 97 and they just want to be comfortable. So basal cells are most common, and they can really look like anything, especially when they're pigmented. They can be really tricky, but I just wanted to put this up here so you know that they can be pretty destructive. They have a tendency to get ulcerated in the center depending on the type. The more invasive, the larger they're going to get. They have a very low risk of spreading to anywhere else in the body, but they are locally destructive. Yes, I have had some patients who have had metastatic basal cell, but those are folks who were left it untreated for decades. Very rare to occur, but it can occur, so identifying these things early on is important. Squamous cell carcinoma, second most common type, if left untreated, can be life-threatening. So really, as long as it's under the size of a golf ball, less likely to be invasive. If it's in a special site, like the lips, genital area, or head and neck area, higher risk. So doing node exams on those folks is important. But those folks should already be established with derm. Risk factors really for all skin cancers are essentially the same. So fair skin, light eyes, sunburn history, occupation that resulted in lots of sun exposure, chemical exposure, folks who have genital warts, folks who are immunosuppressed. These are all areas that you want to be checking, asking about, making sure that you're monitoring for a skin cancer developing. But this person here, I just wanted to point out, so over here, you can see that person is covered with actinic keratoses, but that area that is circled, that is a squamous cell carcinoma. So less than 1% of these actinic keratoses will develop into squamous cell carcinomas, but getting those treated, getting them in with dermatology is critical, because when you have that much actinic damage, your risk is much, much higher, the cumulative risk. And then I want to show you Merkel cells, which are incredibly rare, but they can look like anything. Oftentimes when those are diagnosed, they've already metastasized, so very poor prognosis for these folks. So any lesion that you find that just doesn't fit right, make sure these folks get to dermatology quick, get a photo. If you just are really concerned, if you don't have a dermatologist you can just call up, I would try and develop that relationship early on and see if you can kind of bypass these long wait times for some patients. And then melanoma can really look like anything and can be anywhere. So just wanted to demonstrate these. So no matter what, by the time these patients, they're geriatric patients, they've already accumulated all these risks. But practicing safe sun is still important because it's going to help their immune response as they are being exposed. So they have the damage, it's giving their immune system the time to kind of resolve itself, but getting a good skincare routine for all of your patients, recommending practicing safe sun, it's going to really matter a lot for when they do reach the geriatric age. So One thing I wanted to make very clear is that a baseline tan is never a good thing. I know some providers who have recommended that to prevent sunburns as a preventative, so I just wanted to make that very clear. Tanning bed use, even using it just one time, our studies show increases the risk of every type of skin cancer, especially melanoma. We're seeing lots of melanomas in our 30-year-olds, 40-year-olds. I've had several in 20-year-olds, and a lot of times these folks have a history of tanning bed use. There is a genetic component. There are familial syndromes that increase the risk, but it's just really, really important to make sure these folks know that they need to protect themselves and that a baseline tan and tanning beds are never good. The American Academy of Dermatology has really nice handouts that you can get or you can print out for patients to understand what to look for in self-screening, and lots of really great resources for you to access as well if you have any questions. You can access that here on their website. And then another great CME that the Journal of the American Academy of Dermatology put together is here with different primary and secondary preventative measures that you can take for your patients regardless of age. So I would highly recommend perusing that. I think it's a really great resource. So key points: geriatric patients, they're going to have skin changes. We're going to see them to varying degrees. Many of them will require derm care and referral, but you're the first line, so having those tools, having those handouts, having those counseling sessions can really make a difference, make them feel more comfortable as they're waiting for these derm appointments. And early identification can really save a life, so if you don't feel right, fight for your patients. They really need it, and sometimes they don't have the family that can request that help. So you guys are doing big work. So fight for them. These are my references, and we're done early.
Any questions for Dr. Al-Hajj? All right, we'll start back at 8. Guys, it's 8 o'clock. Our next presentation will be J.C. Worrell. J.C. Worrell, MPA, brings people and organizations together to improve health outcomes through policy and programs. She's a listener, strategic thinker, and achiever who maintains the best way to affect positive change is through community engagement, education, and pairing direct services with advocacy. She is the Chief Executive Officer of the Rural Health Association of Tennessee, a 501c3 nonprofit established to lead the way for a health tomorrow throughout rural Tennessee through partnership, advocacy, education, and resources. Please help me welcome Ms. J. Worrell.
Thank you, and good morning, everyone. It's always an awkward thing listening to someone read your bio. But thank you. Yep, so J.C. Worrell, as he said, Chief Executive Officer, Rural Health Association of Tennessee. Just out of curiosity, how many of you are based in Tennessee? So everybody else's hand will go up for being out of state? Okay, cool. I will try to make some connections for you all. We're not going to just talk about Tennessee, but definitely want to give you an overview of what we see as some of the biggest challenges and opportunities in rural health. So is this the clicker? The big green button. Okay, cool. Here we go. Okay, so the required disclosure side. I think of the key things to know about us in this respect is we are, as a 501c3, that means we're charitable status in nature. And in our case, it means we're largely grant supported. So a lot of our funding comes from state dollars or federal dollars. I have a couple of federal HRSA grants, a couple of private contracts, but those are things like we have a subcontract with Vanderbilt University, Jackson State. So that is our world. We believe nonprofits should be transparent. And so we do have a platinum seal of transparency on guidestar.org. That's a good tip for you all if you're looking into any nonprofit. Highly encourage that. Okay, session objectives. Going to start with what is rural. It's not as easy as you think to define, and lots of different definitions. Talk about the advantages of practicing in rural settings, the hardships of practicing in rural settings. What I hear is common wish lists, and would love to hear for those of you that might practice in rural, what those things might be as well. And then I always like to end on policy, because so much of what we do in all healthcare, not just rural health, depends on our state level and federal level policy. So I always like to give people an update on that. Is there anything else that people kind of would like to talk about or you're curious about? If there is, and we kind of go along, feel free to raise your hand, interrupt. The world of rural health, again, like all healthcare, is so wide. There's so many different directions you could go when talking about rural health, and so I'm happy to pivot. May not have all the answers, but I will speculate with you and maybe guess and point you to some other resources. Okay, so first about Rural Health Association of Tennessee, we, as I said earlier, are a nonprofit organization. We're membership-based. We've got more than 800 members that represent all 95 of Tennessee's counties. Our members include school health professionals. So Tennessee is unique in that we are the only state that funds our own coordinated school health program. Other states have coordinated school health. They're typically federally funded if they have one at all. So I want to say 15 years, maybe 20 now, or so ago, we as a state have funded our own coordinated school health. So they are members of our association. Of course, we've got hospitals and clinics. people sometimes call us the Rural Hospital Association. Unfortunately, if I relied on hospitals only as my membership, I would not have an association. There just aren't that many of them, unfortunately. We've got a lot of mental and behavioral health providers. That's something that our membership increasingly, whether they were the school health people or the clinics, they kept saying we need and want more education on mental and behavioral health. And so we started offering more of those topics, and then came the mental and behavioral health crowd as our members, and then a lot of community-based organizations. So sometimes it could be a county or a city mayor, EMS providers, really anyone that cares about rural health. And for those of you out of state, I will say that there is a rural health association in every state. We're all going to look very different in what we do and what we have the capacity to do because of funding or how we're structured. So we're quite large. Is anyone from Virginia? Virginia's got a really great rural health association. Beth O'Connor is the director there. New England, they've kind of got multiple states into one association. Anybody from Florida? Florida Rural Health is tied into what they call the AHEC program, Area Health Education Center. So we all look different, and it's really just because of our funding structure, how we were set up in the first place. But what I would say to you all, though, is if you have interest in rural health, or if you have a passion for policy and really bringing the issues that you learn about through your practice to life, your Rural Health Association is probably a really great first place to start. And then there's also National Rural Health Association. And in that membership, of course, we've got the hospitals, but the federally qualified health centers, the clinics, and all those things. The National Rural Health Association has a lot of really, really great resources on their website. If you're ever interested in that, they have a great conference every year. So while I'm from Tennessee, there should be another organization for you to connect with. Our mission here at our Tennessee Association is to lead the way to a healthy tomorrow through partnerships, education, advocacy, and resources. And the way we approach our work really aims to stay true to our vision for every rural community to have the resources and the support that they need to achieve health and prosperity. So one of the reasons we've grown so much and have done so well is because I take every opportunity I can to find those federal dollars, find those state dollars, and then I'm not just keeping them for ourselves as an association, but we try to pass that money back out to rural providers as we are able. It's never enough, but as I'm sure many of you can empathize with, a little can go a long way in a rural community. So what is rural? I have to look at the big screen. I'm so glad I'm at this phase in my life where I need these readers and I never know up or down. So it's really nice having this big screen. So I have been told that there are more than 90 definitions of rural in the federal government. And that's because different programs that come along or different funding opportunities, the question is who's going to be eligible for this service or this thing or this offering, this grant? And out of that have come so many different definitions. So the Census Bureau is anything greater than 2,500 people, which is really, So obviously some of y'all are in rural communities that have more than 2,500 people, and you can attest it's still rural. HRSA is one that we use, and basically it says non-metropolitan. You could do a search on the internet to say rural health eligibility for grants, or HRSA rural health eligibility, and that tool will give you can put in your address and it'll tell you if you're rural or not. And I can tell you it's not always right the way we would define it. So how many of you live or work in a rural area per any of these definitions? Okay, so we've got a semi-rural crowd. Well, the next few slides, I asked ChatGPT to give me a picture of what they I don't know what are we calling ChatGPT? Asked ChatGPT to produce a picture of the quintessential, what is your interpretation of rural in Tennessee? So I just wanted a photo, and this is what it produced. So that, it's a pretty good rural picture. I think a lot of us would probably think of that. But then, you know, in the interest of being inclusive and knowing that rural can mean different things to different people, I asked the same thing, but for Alaska. And this is what it produced. I will confess, I told it to put more snow in. The first picture had a little less snow, and I didn't think it was obvious enough. So I said, that's a good picture, but please more snow. And then it came up with this one. So the first one had a little red truck in it too. Fun, but so yeah, you know, rural in Tennessee is not rural in Alaska. Neither is it rural in the Southwest. So I asked for a picture. I don't know if I said New Mexico or Arizona, but I wanted I was imagining like Indian reservation country and kind of brown, and this is what it gave me. I don't know how accurate that is, honestly, but definitely I do have some colleagues that work in other states, and they talk about being on the res and the challenges with resources. So that's what ChatGPT said. Then I asked, because I've specifically in my mind, I'm thinking like a school buildings. I always think it's really unique in a lot of small communities how the high school, middle school, and elementary school are like all right there together. So I asked for a Midwest rural community where you can see all the schools, and it delivered. And then the last one that I asked, I and my husband and I, we vacation in Apalachicola, Forgotten Coast area of Florida. So I wanted, and it is rural. So I wanted something that's kind of a little bit more coastal rural, and once again, delivered. So, you know, really interesting, and with the exception of the school buildings, I didn't say, you know, produce me a boat or a mountain or a thing. I just kind of said, what is rural? So the next picture, though, is what I think of when I think of rural communities. This is going to be a picture of my hometown. I'm originally from Greene County, Kentucky. And I think of rural as really vibrant communities with hometown celebrations and people that know each other and very smart, intelligent, contributing to society people. So this picture is our annual event. It happens every September if you'd like to go. It's called Cow Days. There is a parade. I will tell you, I'm very disappointed in the marching band here. That would not have flown in my day. They look off step. They're not exactly in line. I think it was their B team for this picture, but the rest of the band must have been at a competition or something. But this is what our community looks like. Greene County is known for having the oldest courthouse west of the Allegheny Mountains. We're known for ski, which is like a Mountain Dew with more sugar and more caffeine. It used to be bottled there. But it takes about 45 minutes to an hour to get to an interstate, but really great community. So I think that's something that we don't, you know, unfortunately, there's a kind of double-edged sword when we're talking about rural communities in terms of like branding ourselves, and this comes into play when we're talking about provider recruitment and practicing in rural areas. Is you know, a lot of people that don't have experience in rural communities really don't understand some of those pros of those, exactly how vibrant they think of those vast, wide open spaces with no people around like ChatGPT just did. So, advantages of rural practices, and I would love to hear what you all have to say about this, but again, I talk to a lot of student groups throughout the year, and there are a couple of myths I have to dispel when I'm talking to student groups. One is that you can't make any money in rural. That's not true. There are people that call me every single day wanting to buy a rural clinic, or a company that has a product that they want to sell to a rural hospital. And they wouldn't do that if they haven't done their market research and they didn't think that there was some sort of opportunity there. So, is it maybe different money or different, you know, maybe you cap out quicker? I think those are things to say, but to say you can't make any money in rural is one of those things that I have to dispel. So when I'm talking to those student groups, I talk about the close provider-patient relationships. I think that that's something that a lot of people that go into medicine really want, to have those relationship-based interactions with their patients. A little bit broader scope of practice. I get nervous when I say scope of practice. I probably should have found a different word for that. But I think in general, you know, there's a sense that, like, there's a pediatrician practice that I talked to who she doesn't just do the vaccines and the bruised knee. She's doing mental health and you know, a lot more kind of beyond what she had thought that she would be doing when she went into practice. And I think that's the case a lot, is that there's a lot more, I guess, maybe less specialty care. Greater provider autonomy. I hear this a lot, and especially for our providers that have that entrepreneurial spirit, and they really kind of, they have in their mind, you know, this is what great medicine is, and this is how I want to deliver. I think that you can do that when you're in independent practice. Community trust and leadership. I think we've always known this to be true, but especially during COVID, everybody from the state agencies, the universities, was coming to us, and they wanted to connect with that rural provider because they knew that that was the trusted partner in the community. And then a high sense of mission, and I definitely see that in our membership. You know, we've got some people that have independent practices that they just absolutely love what they do. They love that they're making a difference, and they actually get to see it because they get to see their patients on a more regular basis, whereas, and you all can always correct me if I'm wrong, but I've often heard from some of our urban and suburban is that, you know, people get lost in the system a little bit more, and so they don't always, you know, get to see the full picture journey. Anybody have anything to add to that? Advantages? We had about at least a third of y'all say you're practicing in rural. Would you agree with this or disagree with any of this? Agreed? I'm seeing agrees. Okay, so barriers in rural care, and you know, unfortunately, these are the things that we hear about and talk about the most, and it's for a reason, because you know, as an advocacy organization or providers that are under-resourced, we have to talk about these things. But I would say there's a lot of nuance to them. So we always talk about the workforce shortage, and I feel like that's a really nuanced conversation as well. It's not just like the service industry, we don't have enough workers. It's more about really having those specialty care providers. I hear a lot in my work that once, like the hospital, or if there's maybe a little bit larger of a clinic umbrella, once you get people in the positions, they don't tend to leave. Like, they really like them. So it was something, Rural Health Association, we had a workforce development program early on, and our goal was to place certified nursing assistants. And it turned out they're like, yeah, we don't have enough, but actually all of our positions are filled. So it's a really nuanced conversation, community by community, but really we're typically talking about specialty cares such as behavioral and mental health, OB, of course, and then depending on the community, primary and preventive care. So in my world, I spend a lot of time talking to state administrators and legislators to remind them that healthcare is not just hospitals. It's not just emergent care. That's really important. Tennessee has the second highest rural hospital closure rate, second only behind Texas. And so that's a talking point for the Medicaid expansion advocates and others, but also we have a lot of communities that never had a hospital in the first place. And we've got communities that might have emergent care, but they don't have primary care, or they don't have long-term care for seniors. Limited infrastructure, and this is a tough one. A lot of our hospitals are old. They were built in the Hill-Burton era. Did I say that right? Or I always wonder if it's Hill-Burton or Burton-Hill. Hill-Burton, thank you. So, even the hospitals in Tennessee that have closed and new operators come in to try to reopen it, the stories that I've heard about getting that building up to code are just unreal. I've heard stories in Brownsville, actually, in West Tennessee. One of the reasons they had trouble opening was because the sprinkler system, it was installed, but apparently it wasn't ever hooked up. And they had gone 30 years without knowing that. And so, lots of things that they kind of uncover in the process. Old equipment. I would even say digital infrastructure in this. I'm learning more and more about how clinics in some of the smaller hospitals, one of their greatest challenges is just operating at the top of their electronic health record system, right? So they've got these really awesome systems and don't know how to use them, or they haven't had support to do that. So I would include that in there. Regulatory and administrative burdens. So the fact of the nature is, in rural communities, we're working with Medicaid and Medicare population more so, and with that becomes extra documentation and cost reports and all of the things. So that's something that I hear about a lot. Lack of financial incentives, underinvestment, and social drivers. And so that's really, we see this in Tennessee a lot, that, you might have a great healthcare system, but everything else in the community is limited in resources. There's no food pantry, there's no transportation, there are issues of really long travel times to go to work, and all of those things, obviously, as you all know, impact health. Anything you all would add to this list?
I think you have, where I live, we have a system that where they have purchased a whole group of hospitals, and what they've done is make just 2 or 3 the central portions, so they've shut down the rest of them. My local hospital used to have 60 beds and all kinds of specialties. Now it's down to 4 beds, a nurse practitioner, and an ER doc. So I think that's happened a lot with these big companies purchasing,
Mm-hmm.
and they consolidate everything in the name of consolidation, and it really kills the rural outreach.
Yeah, so the comment, if they're online listeners or didn't get all of that, is talking about the mergers and the acquisitions and the consolidations of the healthcare system. And, you know, it's a really hard thing. So on our association, one of my former board presidents is the CEO of a small hospital, and she ended up, her hospital joined St. Thomas Ascension. And so, you know, had a lot of conversations about that. And for her in that hospital, she felt like this is the only way, you know, we're going to maintain any services at all. And there's that balance of, you've got, when you're part of a larger system, you've got the HR and the admin and the lawyers and the billers and you know, you've got that like administrative backbone. But you know, they did lose services, right? Because the idea is just to maintain the basic necessity in the community, and that hospital becomes a feeder. In that situation, you know, that community felt like that was the best decision for them. And then we've got other communities that are fighting tooth and nail to say that we want to maintain independent. We will go in, we're good with strong partnerships and referral systems and networks, but they want to maintain that community control. And in some cases, they actively want to maintain a service such as labor and delivery, that they know the labor and delivery doesn't make revenue, but because we can offer this other service, and they make those active choices. So it's interesting. There's a book, I'll have to look up the author's name, but the book is called The Hospital, and it basically, the whole premise is looking at the mergers and the acquisitions and kind of like the growth of the big systems, but health outcomes are not improving. And I think that's the biggest frustration. It's there's one thing to maintain services and, you know, keep a strong system and infrastructure, and all of that sounds good, but at the very core of what we're doing, we're trying to help people be healthy, get healthy, maintain good health. So, you know, I think that's something that that needs more attention called to. Any other barriers that anyone wants to add before I move on? Okay, so long wish list, and definitely interested in what you all may have here. The first one is stable and flexible funding. So in the communities that we're talking about, they don't just want grant dollars. Grant dollars are fine. They're not going to turn them away. But really wanting that stable and flexible long-term, basically a favorable policy environment that gives favorable reimbursement so that they can, you know, focus on delivering good medicine. Payment parity for rural providers, we see this a lot. And in Tennessee, we've got the issue of what we call the uninsured adult safety net. And I'm not going to get into all of it, but basically there are communities that have high uninsured rates, but the rural providers are not eligible for applying for safety net dollars that would allow them to provide some basic level care for uninsured. So, but of course, parity extends beyond that. Workforce incentives and pipelines, we hear this all the time. And so, you know, it's really about introducing youth to rural, not advancing the false narratives that you can't make money in rural. Lots of state and federal loan repayment type programs that students can take advantage of. But more and more at the state levels, I think they're trying to build really solid relationships with high schools, even middle schools, to introduce young people to careers in healthcare. So a lot of youth, they only think of doctor, nurse, dentist, and they don't know the wide variety. Like, what does that mean? What do different specialty care mean? So that's something that, we hear very often. Sustainable telehealth and broadband, again, a tricky one, but, as the digital age keeps accelerating rapidly, there's an awareness that, there's a lot to be done there. High sense of mission, I don't know why that's here. Maybe our legislators should have a high sense of mission. I don't know. And favorable policies. Does that resonate? Anybody? This is your chance to complain in a safe space. What do you want? Tell me. I'll go talk to people. I can't get it for you probably, but anything else? Yes.
Some of the patients did not have any, I think they need to have like a copay, even if it's $5, just something, because sometimes they would just really abuse the system. And then it just makes a traffic jam of payments and stuff, and sometimes it's not fair. Like a person will come in and their kid has the sniffles. Well, why don't you see all 5 of them while you're here? None of them were sick. They had a cough, cold, but we had to bill, and it's overwhelming the system, I think. So if they could just make just a small kind of deterrent for, if it's serious, of course, we'll see them. But if it's something stupid like a cold, I'm sorry, I mean stupid, there's nothing you could do, supportive care and things like that. But I think that would be a good deterrent for maybe weeding out the stuff that doesn't need to be seen.
Yeah. Yeah, I mean, I think I agree with that, and that's something that, I hear brought up a lot. I think there are a couple levels to that. We do work with a lot of clinics to help implement sliding fee scales, to kind of look at that income and, is that $5 per kid for 6 kids affordable? So you've got that level in that. And then I think that's kind of a broader, when I was talking about social drivers of health and food and transportation, I do think that there's a lot more to be done and said for healthcare literacy. Just too many people, they don't know the difference between emergent care, other care. And to your point, I think that's one of the biggest costs to our state Medicaid system. I can't speak for the other states. I'm guessing that's going to be true. Are people going to that ER for a non-emergent need is very costly. So that's definitely part of it too. So there's that healthcare literacy, but then there's, when you think about that too, that kind of goes back to the need for more primary care and those relationships, because a lot of people don't know, they only know the hospital. I think that's where we get. So yeah, definitely that's part of the issue too. And then doing that consistently so that anybody, no matter the community, knows I'm going to have to pay the $5, or this is what we can do, or not do. It's a good one.
In a lot of cases, they're replacing, I know in my system, they're replacing physicians with nurse practitioners for primary care, which is a disaster with our aging population and complex problems, just to save money. And so we see, where there's a dearth of primary care, they replace them with nurse practitioners to save money, and that's a disaster.
In the hospital
I do emergency
setting?
medicine, yeah. Well, yeah, it's a system, but a lot of places are doing that to save money.
Yeah.
And I think that's a really, really bad idea with our aging population.
Yeah. Yep. That's something we have a lot of statewide conversation. I saw Dr. Loikie just left. He knows that that's something our legislative committee has talked about a lot. So to be a federally certified rural health clinic by CMS, those can be nurse practitioner owned, certified midwife, licensed clinical social worker, that mid-level provider, but they do still have that physician oversight. And so, you know, that's been around since the 70s at the federal level. That rural health clinic program came about the same time as our federally qualified health centers. Does anyone work for an FQHC in here? Okay, great. Okay, yeah, so y'all know what we're talking about. So, so there's a lot of oversight and, you know, again, that administrative burden to operate an FQ or an RHC. So, yeah, I mean, it's a tough thing. And I can tell you, to your point, too, I think that people in rural communities, they want to know they're getting the best care, right? They want the best care. So I think, you know, there's something to be said. But if you're in a shortage area, and if it's someone to see your cold, you know, nurse practitioner might be that person. And so I think that's where really good partnerships come into play, and why those are really necessary. It's just having really, really good relationships with other providers in your community or in your region are definitely important. Okay, so I'm going to round out the last little piece bit here, talking about some of the before I do that, when I said rural health clinics, do any of you work in a rural health clinic by CMS? Okay, 3 of you do. 4. Okay. I was just curious. And are you all in Tennessee? No? What state are you in? West Virginia. Okay. We've been doing a lot of advocacy for our rural health clinics because we're learning that just people, you know, don't understand them. And so if there's any support or questions around that, I'm happy to go into that a little bit more. But yeah, so the next little piece here, I just want to give you some of the policy updates from the National Rural Health Association. People seem to appreciate those. The only thing is that I was worried about is it's changing so quickly right now. By the time I put in a slide, tomorrow it'll be different, and I had to give these. I was supposed to give them like a month ago. I gave them 2 weeks ago, so things have already changed. But some of the updates when it comes to some of our federal level policy and how it may impact rural communities. So there was, so the president usually releases a budget February, March. It's usually a symbolic budget that kind of, every administration, left or right, there are things where, you know, it will be zeroed out in that budget. And then that's where the advocates come and say, no, we really like that program. Please keep that in your budget. So that has been pushed back this year. And we've been following, you know, what's happening, what are happening to some of our rural health programs. So in the leaked draft of the president's budget, which now there's a little bit more information in a newer one, but there were several rural health programs proposed to be cut. So first of all, the Health and Human Services Agency, I guess they're going to be part of AHA. And that's what they're actually calling it, is the America Healthy something. What's AHA? Somebody's watching the news in here. Make America Health. Okay. But they are calling it AHA because everybody giggled about it at the conference I was at a few weeks ago. They're like, well, everybody's saying AHA. So we'll get to that. So no specific program funding levels yet. It says expected in June. Here we are in June. We've got a few things that we are seeing, but overall, HHS, we're seeing a 26.2 cut from what was originally planned. That's $7.2 billion for HRSA, which is the Health Resources Services Agency. That's where our FQs get a lot of funding from. It's where our critical access hospitals get a lot of funding from, and others. A $3 billion cut in discretionary funding, and then a $5.6 billion discretionary funding for CDC. In the appropriations, so here was the aha. The primary care office would be funded. So basically, it's just a reorg. That's all it is, y'all. It's just a reorg and a new name. So, but as they're going through it, they're bringing HHS under the umbrella, they're bringing SAMHSA under the umbrella, and moving some programs around. But there you'll see in that left column the health services outreach, rural health research and policy development, RCORE, which is rural community opioid response, telehealth, and community health centers, which are FQs primarily. So those things are still being funded. It does look like the CDC Office of Rural Health, that's a tricky one. It was approved several years ago. It's not actually made it in the budget yet. So there's been a number assigned to it, but it hasn't actually gone through yet. So still to be determined about that. But then the programs proposed to be cut. Who works for a critical access hospital in here? Anybody? Okay. Sorry. So yeah, our flex programs, our SHIP programs, our state offices of rural health, some rural residency planning program was proposed to be cut. I will have a really hard time believing that sticks based on what I shared earlier. Number one thing we're always hearing about is workforce and the need to build those pipelines and have those program certified community behavioral health centers, AHECs, area health education centers, which again, those can look very different state to state as well. Behavioral health workforce training, oral health training, some of the nursing programs, and most of the SAMHSA programs. So as of right now, all of these things are still on the chopping block. So if your community has a critical access hospital and they benefit from those flex or state grants, if you, especially the hospitalization, stabilization, if those are things that your community relies on, really highly encourage you to send a message to your state legislatures to talk about what those programs do for your communities. The National Rural Health does have several advocacy tools and sample letters that you can go to and use if you feel like, oh, I don't know, I've never talked to a legislator, or I don't know exactly what the FLEX program does, I just know that our hospital has it, or that it's important to our community. There are all sorts of resources there, as well as Medicaid advocacy. My next slide will be talking about that a little bit. I'm not going to get into the weeds of it because, again, it's changing on a daily basis, but we really do have to communicate how important Medicaid is to our communities, to our hospitals, to our clinics. So all sorts of resources there that you can go to. And then, of course, just so you know, the National Rural Health Association, they never, ever support a bill that does not have both a Democrat and a Republican on the ticket. So the National Rural Health is always uber careful and intentional about putting forth proposals that both sides are working towards. And thankfully, in rural health, we've historically had bipartisan agreement and support. So I just say that because, I'm in Tennessee here, so, and I know how sensitive advocacy can feel. So I just want to say, we're really careful in our language. We really do try to hit that middle ground and really make the case for this is about the communities that we serve and the facilities that we serve, not coming out of any political ideology. So, but we do a lot with other, obviously the Hospital Association, the health education centers, and others. Medicaid, so, lots of changes proposed for Medicaid, and that's always, every administration, something that we have to talk about because it is so expensive, right? It is a big part of our national budget. So there are a number of payments. One that I'll talk about a little bit is the work requirements. I think that's going to come into play. And just to be clear, most people on Medicaid do work, or at least in Tennessee, they do work, but they have, like odds and ends jobs, or it's not full-time employment. It's not employment that offers health insurance. And I mean, on theory, we like the 80 hours per month of work requirement. The trouble is the administrative burden. If anybody here ever has had to do anything ever with a state agency, DMV, anything, licensing, all of the things, just think about all the hoops and things that you have to go through. And so that's, really the biggest concern. And we've heard our state agency said that too, is just to manage that administratively, to continuously monitor that and track that and ask people to monitor and track it. Enrollees would be allowed to get marketplace coverage if not compliant with work requirements. That's assuming marketplace coverage is still around. That's still on the chopping block, and some various things there. So definitely be paying attention to what's happening with Medicaid. I think I'm going to skip that. Basically, the marketplace, we still don't know. One good thing is the expanded definition of rural emergency hospital. Anybody have a rural emergency hospital in your state yet? Tennessee does. We've got 2 now. Basically, special designation, because a lot of everything that we do in rural health hinges on that definition of rural and that what is a hospital definition. Okay. I kind of already talked about that. Okay, last thing here, kind of state level priorities. So again, we're talking a lot about infrastructure, helping modernize the buildings or the digital or whatever it is we need. Workforce development. So in Tennessee, we're doing a lot of work on RN to BN, BN to RN. Testing y'all. BN to RN. That was part of the test. So yeah, basically trying to get more nurses in the pipeline. And through program that we have found that there's a lot of barriers even just to the certification programs, which are for a lot of people a good first step. Protection of school meal programs, again, I talked about that coordinated school health group, so that's something that's really important to us. Opioid response, opioid it's really the larger substance use disorder, but because of the opioid fundings that have come out from, are y'all familiar with that? The pharma money, the settlement money that have come back to the states. So basically, because those pharmaceutical companies were found at fault for opioid epidemic, every state has these large settlement dollars. And so we've been doing a lot of advocacy to make sure that those dollars are being put to good use, Affordable Care Act protection, maternal and child health programs. So yeah, those are a lot of the things that we talk about. Okay. Any questions? I think I've just got one more slide left, and that's just like the closing slide. Any questions? Things you had hoped we would talk about? Things you feel like absolutely missing? Okay. Well, I think the big takeaway, if there's just kind of, a few things, first of all, thank you all for the work you do. Even if you are in an urban setting, I'm sure that you are seeing rural patients. It's just the way that it has. We are interconnected on each other. So, really, really grateful for the service that you all provide, especially the osteopathic kind of whole care model. I think is something that we want rural people to experience. And then, if there's any kind of ask, as you hear people talking about rural health or you're talking about rural health, I guess my ask would just be to remember that it's broader than hospitals. It's broader, it's not just that farm, that green farm setting, but we're also talking about the frontier and reservations. And that the conversation is a lot more nuanced than people are willing to go into. Our workforce issues, what exactly does that mean? And I guess that's something, if you've got an opinion, I don't even care what your opinion is. Whatever your opinion is on workforce issues or working with people who are uninsured or on Medicaid, taking those stories to your legislators is so, so important because it is such a nuanced thing. And your stories are what helps make it real for our legislators. And I can promise you they do listen. And it is essentially kind of a numbers game of, if you've got more people saying do away with Medicaid than you've got people saying this is how Medicaid supports my community, then that's a problem. If you've got 0 people saying my state office of rural health has helped me with, or my hospital with this, then that's they're not going to speak up for you. So just really paying attention to those and remembering the nuances and kind of framing it in a way that you can honor the rural communities that you serve, but still make clear the things that your community needs. So last thing here is just about our rural health association. The save the date is actually last year. Sorry you missed the party for that one. But we'll have another conference this year. Rural Health Association of Tennessee has our conference every week, the week before Thanksgiving, in line with National Rural Health Day. We do awards. We have different tracks for hospitals and clinics, mental and behavioral health, school health, public health. We've got regional events. And these are really listening opportunities as much as networking and education opportunities. Is kind of how one of the ways that we as an association keep our ear to the ground. So invite you to join us, or if you're in another state, please connect with your state association. And that concludes my presentation. I'm happy to take any questions, comments. Well, yeah.
Thank you, Ms. Worrell.
Yeah.
That was a lot of information. It was very good. We'll meet back again at 9 o'clock if there's no questions.
Thank you.
All right, guys, we'll go ahead with our next presentation. We have Dr. Ansel Peacock, who is a family medicine physician at Farragut Family Practice in Knoxville, Tennessee. He graduated from the Kentucky College of Osteopathic Medicine in 2017. He went on to complete a traditional rotating internship in Lumberton, North Carolina, followed by a family medicine residency at Lake Cumberland Hospital in Somerset, Kentucky. He practices a full spectrum of family medicine, including pediatrics and osteopathic manipulative therapy. He continues to fill the void in Knoxville by providing inclusive care to the LGBTQ+ community. Please help me welcome Dr. Peacock.
Well, thanks for having me back. It's my third year now. So if you all have been here the last 2 years, you've seen some of these. So this year's kind of the refresher course. Focusing more on the transgender community today versus the full spectrum of the LGBTQ community. So just wanted to kind of, we'll start at the beginning and go from there. So I have no disclosures. So just here because it's fun. And I enjoy teaching about this. Learning objectives today, just again, be able to determine the difference between gender and sex, gender expression, and then also what it means to transition. Being able to diagnose gender dysphoria is something that we can all do. So we'll go through the criteria for that. I'm going to touch a little bit on consistent, insistent, and persistent aspects of the identity. A lot of this comes with the pediatric population. And then the biggest thing is just, how to support and accept these patients because it will positively impact their mental health outcome. And then just kind of give you an update on Tennessee's legislation as far as both social and medical aspects of transition go. So the reason why I keep coming and doing these things is despite all the progress that we're making, there's still just not enough education on it. And so even if it's 25 minutes with me, you've probably maybe not have heard some of this before. And so just getting that little tidbit could kind of push you into the right direction. So again, just trying to increase awareness, increasing the knowledge to be aware of the risks that the population has. But then also to inspire the young people to continue to advocate and take it on and push it through their students and, make this part of an everyday, or just everyday habits, really. So the basics, just to separate sex and gender. So sex is the characteristics that we are born with. These are our genitalia, our chromosomes. It's inherent, so we don't have control over this. And then gender is the social aspects of identity. So this is behavioral, this is cultural, this is psychological. It's, where we say women, and I'm making stereotypes, so don't judge me, everybody, but women should be in the kitchen and men should be in the garage, right? So this is what gender is expected in the social stereotypes. So the genderbread person is my favorite picture. I will show it every single year because I think it's a really good representation of how to separate gender, sex, gender expression, and even identity. So identity is what's in your head. This is who you are as a person inside, how you feel. This, again, can range from that feminine aspect to the masculine aspect or somewhere in the middle. We see a lot of this with the non-binary community. Some intersex people, and we'll kind of get down to that too, can kind of identify somewhere in the middle as well. Gender expression is the clothes that we wear. It's the makeup that we put on. It's how we cut our hair. The colors that we associate with. This is how you express yourself. Your biological sex it's a kind of a mix of the organs and the chromosomes that you're born with. So with chromosomes, most of the time there is a binary, but we do know there are intersex disorders. But then when it comes to genitalia, you may have one of the XX or XY chromosomes, but based on different enzymes that we may or may not have, the exposure to hormones in utero or genitalia doesn't always produce the way it should based on our chromosomes. And then sexual orientation, this is who you love, whether you're attracted to masculine or feminine or somewhere in the middle. But the reason that this is my favorite picture is all of the arrows show a spectrum. So it's not just pointing one way or another. It's anybody can fall on any one of these lines at any point in time. Sometimes it's daily, sometimes they fall on one side. But it's nice to know that it's a spectrum, and I like the visualization of this. So when it comes to the transgender population, these are people whose gender identity does not align with the sex that they were assigned at birth. And so when I'm using terms today, you'll hear me say F to M or M to F. But this starts with the gender they were assigned with at birth, and then the second one is the gender that they align with. So female to male would be someone who's assigned female at birth, and then male to female, someone who's assigned male at birth. You may also see in documentation AFAB or AMAB, and that again just stands for assigned male at birth or assigned female at birth. When it comes to coding, I like to just throw these in here because when you go to type in trans in your documentation, the ICD-10s will pop up for transsexual or transvestite. I try to discourage the use of transsexual. Some of the community still likes it. Other parts of the community feel that this is more derogatory. This is where the term trainee comes from. And so they really don't identify with it, but some people will have a gender-confirming surgery, and then they do tend to lean more towards the transsexual identity. So I always just kind of say, see what verbiage your patient uses and then kind of mimic that. And then transvestite will also pop up. But again, with transvestite, this typically refers to men who will cross-dress and wear makeup, and it's more of a gender expression. It's sometimes used for drag, but it's not has to do anything with their identity. Doesn't have to do with their sexuality. It's just they like to wear the clothes of the other gender, and so you could use this diagnosis code if they're coming to you and it's causing a problem with mental health, right? But in reality, not all trans people are transvestites. So I just want to put that out there just in case you're documenting and you just grab the first one. I prefer to use the ICD-10 for gender dysphoria. So gender dysphoria is the actual DSM-5 diagnosis for someone who identifies as a transgender person. So in adolescents and adults, so typically I say somewhere around 14, 15 years old and older, this is when their experience and expressed gender is starting to cause significant distress. And I think that's the important two words, is significant distress. It then alters their functioning in life. So they have to have at least two of the following for 6 months. So again, a marked incongruence between their expressed gender and their one assigned at birth, as well as their primary and secondary sex characteristics. They have a strong desire to be rid of their own and want the one of the other gender. They want to be seen as the other gender, treated as the other gender, and they have a strong conviction that this is who they are. When it comes to kiddos, a little bit more difficult, so still just that 6 months, but they have to have at least 6 of the following criteria. A lot of them overlap too, so this comes with a strong desire, again, to be the other gender, so you'll have a little toddler telling you, I'm a boy or I'm a girl, and that's not what they were assigned with at birth. They start wearing the other clothes, they want to play with play with toys of the other gender. When they're playing make-believe, there's a lot of cross-gender role play. They have a strong preference for playmates of the gender that they desire to, that they align with. They don't like their own sexual anatomy, etc. So they have to have at least 6 of these for 6 months. So again, that's all the diagnosis consists of, is it causing that significant distress and impairment in function for that 6-month time period? So when it comes to gender and development in childhood, this can be a lecture on itself, but really when it comes to kids, children just naturally become aware of their genitals in infancy. They start becoming more aware of gender characteristics as early as 9 months old, and they start expressing it through 3 years old. Gendered pronouns become a part of their vocabulary as early as 2 to 4 years old. They're usually not very good with it until they're 5 or 6, but they start using the she and he and they and them and everything. So they're becoming more aware of it at that age. Exploring gender is a normal part of development. So someone could still cross role play as the mom or the dad when they're playing house, but doesn't mean that they will then become a transgendered person. So they just start exploring it. And then again, kind of going back to the criteria, you'll start to see maybe that they show interest in the other gender toys. So instead of the typical little girl wanting Barbies, she wants Hot Wheels, right? The biggest 3 words that will kind of play into it, and is insistent, persistent, and consistent. I mean, these kids, they are not going to back down from the fight. They are insistent on who this is. This is who they are. It's persistent. It's going to last a long time. They're not going to back down on it. No matter how many times you try to correct, it's going to be there. And then consistent. So again, it's not going to just be at home or at school. It's going to be throughout all aspects of their life. So again, we're seeing a lot more of these kids seeking treatment and health care. I think a lot of it's becoming just more awareness, more education on it, and trying to figure out what's the best step forward. You'll see them at least stress or behave outside of gender norms, but really a few will go on to actually socially transition, or even gender transition in general. We will see more assigned male at birth patients that will identify as transgender, but more assigned female at birth patients will actually seek gender affirming care. And so I'm not sure how much of that is just society based or whatnot, but that's typically the trend. And then you actually see a high rate of incidence with autism as well in the transgender community. My personal patient load, there's a lot more trans females that I see that have that autism diagnosis as well. But for some reason, there is a slight correlation there. As far as when these kids are becoming aware of their gender and their gender identity, at less than 5 years of age, 32% of the people will tell you this was there before I turned 5. As they get older, so 6 to 10, 28% start to realize who they are. 11 to 15, that 21%, 16 to 20 is 13%, and then after 21 years of age, you still see about 6% of people kind of realizing gender identity. Some of that might be a little bit skewed now too, because again, we have the education and the awareness, and so more people are coming out earlier too, but we'll see how those numbers change as well. So as far as transitioning, what is transitioning? There's social aspects, there's legal aspects, and there's medical aspects. So that's kind of what my previous topics went on. But as far as social legal, that's really just changing name, changing clothes, etc. And then as far as medical goes, we've got the gender affirming hormones and then sex reassignment surgery. But just because you identify as transgender doesn't mean you're going to actually pursue any of this. You can identify and not actually take the steps. So that's important. So social transitioning, I think the most important word on this slide is the first one. This is reversible. So if a child, is starting to think about it, this is a very easy thing that you can do that doesn't cause any permanent changes. So this is reversible, so allowing them to, adopt the hairstyle, change their clothes, play the way they want to, etc. And then simple pronoun usage as well, just using the pronouns that they prefer. So typically you'll see the she, her, hers, or he, him, his. That non-binary identity, you might see they, them, theirs as well. And then I'd like to touch in, as an ally, even if you're not part of the community, sharing your pronouns is really important because it normalizes it. If a transgender person is displaying their pronouns, it almost singles them out. So if everybody does it, they're no longer singled out. That's the importance behind it. And then again, with the legal transitioning, now this is a little bit more permanent, but still able to be changed back, changing their name and gender markers on permanent documents. So it takes a little bit more steps, but you could still reverse it if someone decides to detransition later or something. As far as medically transitioning, again, not going to go into a whole lot of details, but the idea with the younger people is the idea of suppressing puberty, and this is done with GnRH analogs, and again, this is fully reversible. So the idea is to just buy a little bit more time for them to truly, come into who they are, figure out is this what they want or not want, and then when the time comes, if they decide to not transition, you can remove this and puberty will take over as normal. Now, once we start doing cross-gendered hormones, this is where it becomes more partially reversible. So you could stop cross-gender hormones and then their normal hormones would take over. But things like the low voice from testosterone, the facial hair, that really won't go away. Same thing with breast growth. If they go on estradiol, the breasts, may hang around a little bit, but they're not going to go maybe completely flat again. And then surgical transition, The biggest thing on our end as a primary care provider is when to make the right referrals. It's also knowing what type of surgeries are available so that you can kind of help your patient talk through the roles, figure out, what their goals are, et cetera. I make a mention that early intervention is really important. So a lot of times if we allow these children to suppress puberty and then start cross hormones around 16 or 17, we can actually prevent some of these surgeries as well, because they won't need facial feminization, they won't need top surgeries. And so that's kind of where early treatment can be helpful. Most surgeries, again, never happen before 18 years of age, even before laws changed, except for maybe chest surgeries in the transmasculine people. Those typically happened around 16 or 17, because who doesn't want to go to the beach and look like everybody else? So that is probably the biggest one there. And then with puberty suppression, again, the benefits are it allows them a little bit more time. Talked about how, if once you stop it, the endogenous puberty will take back over. But then, again, an easier physical affirmation when it comes to transitioning as well. So the best time to start it is around Tanner stage 2. You can do it a little bit later, but once things start happening at 3 and 4, those really won't be reversed, but you can stop them from continuing on. GRH analogs can be used with cross hormones as well, as the kids get into the late teenage years. And so you can actually sometimes even use lower doses of those cross hormones at the younger ages with the suppression. And then, so again, the things to look out for when you're starting these patients on cross hormones, again, is to look for any types of contraindication. So if there's a family history of, estrogen-sensitive tumors, strokes, blood clots, liver dysfunctions, testosterone-sensitive tumors, polycythemia, and liver dysfunction. So again, as far as the younger kids go, typically you would start these around 16 so they can progress through puberty at the same time as their peers. But then as far as routine monitoring, just like we heard yesterday with testosterone use, it's the same idea. You want to check your hormone levels, renal function, liver function, A1C, and lipids. Typically, my routine is the first year that you're on hormones, it's every 3 months, and then after that, I switch to every 6 as long as you're stable. So that's my routine there. And then the physical changes that we're looking for, so typically in transgender men, we'll start on the left side, they're going to see more beard growth, the clitoromegaly, some acne at the beginning, hair loss, that male pattern baldness comes with it. If they're still binding, watch out for yeast infections under the breasts. And then the surgeries that they may desire would be like a chest reconstruction, so that mastectomy, and then any type of gender-affirming bottom surgeries, like a phalloplasty and mitoidoplasty. And then for transgender women, obviously going for more of that feminine breast shape, they will have more underdeveloped nipples, especially if they start the transition later in life. They're looking for a decrease in that body hair, the facial hair decrease. We have to watch out for inguinal hernias as well. So tucking practices, if you're not aware of, is actually where they take the testicle and put it inside the inguinal canal. And so the dangers of that is you're stretching that inguinal canal out, and so therefore they have an increased risk for that hernia. So I always try to encourage them, try not to tuck longer than you have to. Plus, I always say testicles are on the outside of your body to regulate their body temperature. So if you put them inside of the body, they can't regulate as well, which could increase the risk for any tumors and cancers. So their surgeries may include the orchiectomies, a penectomy with the creation of the clitoris in the vagina, as well as breast augmentation, facial feminization surgeries, laser hair removals, etc. So that's pretty much what this slide talks about as well, is just the basic surgeries. And again, just to touch base, typically these don't be done before 18 years of age anyways. So fertility considerations, just remember cross hormones are not birth control. So again, we talked about how gender and sexuality are very different. So they may be assigned female at birth, but still having male sex partners, or assigned male at birth sex partners. And so if they're using the appropriate organs, pregnancies are still possible. So talking about contraception, whether, are we using condoms, withdrawal method, but you could even use, you can use birth controls. You can use estrogen combination birth controls, but typically I prefer to use more of the progesterone only, and the longer actings are even better because they're going to get more menstrual cycle suppression as well. So the IUDs, the hormonal IUDs, and then the arm implant are excellent for these patients. So when it comes to, as well as fertility, so when you're talking to a kid, you have to start talking about family planning pretty early, because if they have any thought of being a biological parent, you may want to allow normal puberty to take place so that they can develop mature oocytes. If you stop puberty too early, they may not develop mature oocytes. And so trying to figure out, is there a way to bank, their gametes when possible. But as long as they've gone through a natal puberty, biological children are a possibility. So, and has happened. So basic screening, I know I'm running short, so basic screening, again, when in the transgender female population with cardiovascular disease, we're going to have a higher risk of diabetes, obesity. The lipid panels you'll see in a transgender woman, they have higher triglycerides. In transgender men, they're going to have lower HDLs and higher LDLs. So these are not the way we want them to go. And then the big thing with osteoporosis is making sure that we're screening early there. And then, let's see. Just basic, follow the USPTF guidelines, usually for their gender assigned at birth is what I recommend, as long as they have the organs still present. That's kind of the moral of these two, and I can go over these later with people if you want me to. But psychosocial, the biggest thing that I always just caution people about is that this community is already at high risk for mental health concerns. 50% of transgender people have thought about suicide, or if not, at least attempted it. And so I think the biggest thing that we can do as providers or as parents or just as allies and support is just to be there and offer them the acceptance and whatnot, and let them kind of come to you and just be there to support them. But they've shown in kids that the more support they have, the better that they do. The closer that the transgender person's relationship is, so if it's like your mom, your dad, your sibling, the more negative the effect. And so I think the closest people to us can make or break, the people here. So that's probably the biggest part of that one. So different ways that you can kind of help these younger kids, be affirming. Take the affirming approach. Let them make the choice from there. The wait and see method kind of says, well, I'm not going to discourage it, but I'm not going to encourage it, and we're just going to see what happens. So that one is also very good. Redirection and reparative therapy, which is also called conversion therapy, we really tried to avoid these. These are much more negative impacts on the kids, and not just kids, but just anybody when you're trying to tell them that things are wrong. So just, affirming, wait and see, this is probably the best approach to kind of see what's going to happen with gender. And then when we start seeing the suicidality, the depression, this is when it's time to refer to somebody if you don't feel comfortable taking care of it. And then last big slide, legal barriers. So as far as the new Tennessee law, the HB1, SB1, this prohibits all medical providers from doing any type of hormonal aspect or of transition on anybody less than 18. So this does not affect mental health care. This does not affect affirming care. So we are still able to do that, but we just can't start hormones until 18. So that's the biggest thing here. There's a lot more, obviously. There always is, right? But this is just kind of skimming the surface. But this is why I do what I do. So a lot of you have seen this slide, but I'm a transgender male myself. My parents took the wait and see method with me, but I was pretty consistent throughout my life. I had a couple ebbs and flows, but when suicide started crossing my brain and intrusive thoughts started crossing my brain, that's when it was time to make the decision to transition. And I always tell people that I'm the example that it works. Working, married, life is good, and I think that's why I want to just introduce you to a trans person. A lot of us don't know a trans person, and so I think that really can shape people's aspects. But that's all I've got for you. So.
Thank you, Dr. Peacock. We'll save questions for after our next presenter. Our next presenter is Dr. Douglas Leahy, the Director of Student Medical Education at LMU-DCOM. Students for the clinical rotation at Tenova North in Knoxville at the Tenova North Knoxville Medical Center. He is the program director for the internal medicine residency program at at HES Tenova Health, Knoxville. He also serves on the American Medical Association Relative Value Update Committee. Please help me welcome Dr. Leahy.
First of all, happy Father's Day to the fathers. I serve in a number of capacities. One is the program director for the internal medicine residency program and have been the DSME for the students, LMU-DCOM, I guess for about 8 or 10 years. I also serve on the capacity of the American Medical Association called the Relative Update Committee. Most people don't even know what that is. Basically, that's a group that helps determine how you're paid. So we meet on about 3 times a year on issues about payment policy. So if you have any concerns or questions related to those activities, in addition, I'm coding the payment policy for the College of Physicians. So for those of you that are internal medicine interested, if you ever have any questions about that, feel free to call upon me. What we're going to try to do today is basically to look at preoperative care from a generalist standpoint. How many people think that surgery is going up, and how many people think surgery is going up? Are we having more surgery now than we used to, or are we having less? How many say we're going to have more? Yeah. So what's interesting is we're having more and more surgery done because people are living longer. We got better diagnostics. We've got better ways of being able to get people aware of early screening, et cetera. So the important part about this is that you as the generalists are essential to care of these patients. I was listening recently to someone that was doing CAR-T therapy for lymphomas, et cetera, and also the sophisticated stuff with that. And they were asking what was the most problematic for that. And what they said is that frequently when you rev up the T cells to take care of the cancer, you get hypothyroidism, you got these endocrinopathies, which they often miss. And they were talking about how important it is to have someone who takes care of that patient and looks at that patient. So your role as an advanced care practitioner or generalist, internist, family medicine, whatever the case may be, it's essential that you have an understanding and are able to pick up these issues, because it's often you that will see that, even though you have these super subspecialists that do incredible things. And as we're doing more and more surgery earlier, et cetera, I think understanding risk related to the preoperative world is essential. Preoperative evaluation and surgical care should be intimately involved in the total medical care when you deliver it. Should be remembered that 1/3 of all patients over the age of 65 are at increased risk of complications. 1/3 of all the patients over 65, which certainly I am, they're at risk of complications. Our job is to do a risk assessment and try to mitigate or institute therapies to improve the outcomes of those patients. An excellent history and physical is essential. I don't know how often that we remind ourselves of when we do that history and physical preoperatively, we ask the questions, and often it comes up, well, have you got any family history of anything? No, I really don't. Well, tell me about your family history. Well, I had my brother was playing tennis or running and he died. Well, Bugatti syndrome. You know, is there a history of bleeding disorder in your family? Is there issues related to the fact that somebody had a cardiomyopathy? You know, is there physical findings or laboratory abnormalities? So working through that history and physical when you see a patient preoperatively is one of the most important parts that you do when you move forward on it. Now, whenever you're looking at this preoperative evaluation, there are certain metrics that you're looking at. There's calculations that need to be looked at. In the reference, there is the internal medicine, Annals of Internal Medicine that's in there in that reference. It'll have most of the things I'm speaking about, and also the calculation tables, and also has a neat sheet that you can give to your patient when you're explaining preoperative evaluation, and I would encourage you to do that. So we look at metrics. First of all is urgency and timing. Obviously, if they're at immediate risk, you're going to proceed to surgery. If it's urgent risk, then you want to look, if you want to move them quickly, but you want to be sure maybe you could correct the potassium, or you do something along those lines related. If it's time sensitive, they got breast cancer, or maybe they've got an aneurysm that's been slowly increasing, then you got time to weigh that in. And of course, if it's an elective surgery, you got plenty of time to mitigate these things. But you want to first of all look where you are relating to that sense of timing and urgency when you look at it. Let's see if I can get this working right. So let's see here. Green line is this. There. First of all, I have no conflict of interest. And as we mentioned before, the important thing is identify these risk factors and identify them and try to mitigate them if at all possible. One of the early things that was done really almost 80 years ago was by anesthesia. And what they did was to look at the functionality and correlate it with the amount of risk of surgery. So you can see if you got a stage 1 who's healthy, no diseases outside of the surgical issue that you're addressing, then the perioperative mortality is certainly low, along with the level 2, where they have mild to moderate disturbance in some of their blood pressures, et cetera. They have low risk. But as you move up the pecking order, if you can see that they start having disturbance that limit their activity, then they move up to 3, and you automatically see the incidence rise. If they have systemic symptoms that are very severe, it gets to 8%, and if they're severely ill, you can see where they are related to the risk related to it. So you want to look at the overall risk compared to where they are. And I think even though this is an old a metric, I think it still remains important to us. The main thing that you want to look at is the cardiac risk, because about 1/3 of all the complications that occur, with surgery are going to be in cardiovascular areas. So you want to be very sensitive to it. Now, there's two really recognized calculators that they use. One of them is the Revised Cardiac Risk Index. The other one is NSQIP, National Surgery Quality Improvement Program. One of the things that surgeons do that's really good, they compile all these cases and they send them into the surgical groups, and they're able to look at this data. But as you can see, they look at certain things that are really important. Part of which is that along with the risk factors of the patient, you want to look at what is the procedure. Some of the procedures, they'll look at low, intermediate, and also high risk. So low would be breast biopsy. Intermediate would be hip surgery. On the other hand, high risk would be fixing an intra-abdominal aortic aneurysm going through the abdomen or surgically or whatever, although we do a lot of endovascular stuff. So they look at that, and so what they do is they bring these calculations together. So they look at things like intra-abdominal, intrathoracic, and those sort of surgeries. They look at whether the patient has ischemic heart disease, if they have elevated creatinine, if they're a diabetic and they're on insulin, if they've had a previous stroke or ischemic event. Then they compute this together and you come up with this risk score that gives you an understanding of where you are. NSQIP, on the other hand, they look at certain CPT codes that allow them, whether you've had a myocardial infarction within the last several months. They look at it whether it's elective or emergent. They look at your age, your gender. They look for symptoms of congestive heart failure in 30 days, previous cardiac arrest, hypertension, renal failure, diabetes, functional class, etc. So whenever you're looking at this, you'll want to get familiar with this NSQIP scoring, and you can pull it up. It has a calculator, and look at that. It'll help you to some degree to look at where you are related to that in terms of the patient's specific risk, and also it does correlate to some degree of where the overall procedure risk is related to it. Because what you're looking at is you're looking at both the procedure risk and the patient-specific risk, because you want to bring those together in the framework of the urgency of the surgery to help you better understand it. The other thing that's related to this is what they call the Duke Activity Status Index. And so this shows you the METs of what you do. You want to be sure that these people are able to do at least 4 METs. So if someone is not able to perform at that level, that's going to trigger additional testing that needs to be done. So you can see, for example, basically if you can rake leaves or you can climb 2 flights of stairs, that's a pretty good indication that you're functionally able to tolerate that surgery if you look at the other risk factors associated. So you always want to ask those questions in your history and physical, because if they can't do that, it's going to create some problems for you in terms of considerations of whether they need to proceed with it. So the way we look at it, you look at the clinical condition. If they're enact asymptomatic functional capacity, they can do greater than 4 mets, you proceed with surgery. If they do less than 4 mets, then that'll initiate some cardiac testing, which we'll mention momentarily. And if they're active and have some symptomatic conditions, you want to be sure that you get those stabilized, the cholesterol under control, blood pressure under control, those areas that might make it the surgery work in a better manner. So it's important to look at those areas. So with the cardiac testing, you'll get into areas that you might want to look at, such as EKGs, treadmills, echocardiograms, et cetera. We'll talk about that more in a minute. So in terms of the procedure itself, again, to reiterate, if it's a low risk, again, if you're doing a breast biopsy, et cetera, the risk is ultimately about less than 1%. You start getting into intermediate risk where you're starting to do, say, an asymptomatic carotid artery, things like that, gallbladder resection, then the risk can be up to 1 to 5%. But in these high risk where you're doing like a cystectomy or you're doing a pneumonectomy, you get up to 5%. So you always want to look at your procedural risk and correlate it with the patient risk and see if you can modify that or mitigate that to move forward with it. So the things that we consider, particularly in cardiac risk, that's significant, if someone has acute coronary syndrome, that puts them in a high risk category. If they've had a recent MI and they also have greater than 1 month and they're having persistent symptoms, that puts them in high risk. If they have an unstable arrhythmia, if they're having atrial fibrillation that's poorly controlled, or they're having decompensated congestive heart failure, if they're having symptomatic valvular disease, for example, if they have aortic stenosis and all of a sudden you've done an echo and they're less than 1 centimeter square and they're starting to have shortness of breath or syncope or chest pain, you're in a high risk category and you need to perk up your ears for that as well. If there's a patient that has multiple risk factors, hypertension, diabetes, poorly controlled, all those sort of things, that puts them in a high risk in terms of patient risk category related to it. If people are over the age of 65 and basically that they don't have any high risk, don't have any risk factors, diabetes, hypertension, which of course would be highly unusual, then basically they don't need to have extensive testing unless they're a high risk. But for most of our patients who are at 65, they have risk factors. So for intermediate risk surgery or high risk surgery, you want to do the following things. One, you want to get an EKG on them. You want to go ahead and do biomarkers. And so what that would be, you would want to go ahead and get troponins. You'd want to get BNP upon them 24 hours before the surgery, and then do it 48 and 72 hours afterwards if they're in those categories of intermediate or high risk, because obviously they're at risk of having some sort of myocardial event. And so you want to be sure that you monitor those people very carefully. If they do have those high risk categories and high risk procedures, particularly you identify those are the ones you want to reach out to cardiology and let them jump in on top of it and give you some backup on it. If they're low risk surgery and they're low risk procedure, you may be able to get by without having to do that. So you want to look at that, and then when you see those risk factors and you see that high risk of the procedure, that's the time that you want to reach out for the specialist. If you're doing high risk surgery on anybody now over the age of 45, then you want to get an EKG, and you also want to do biomarkers before and after the surgery related to it. If you have a family history, and this is where it's important to get your family history, if they got a history of, say, cardiomyopathy, IHSS in their family, they've never had any problems, it's a good idea to go ahead and get an EKG and an echocardiogram on those people, because a lot of times they may get in trouble because, as you remember, when you have surgery, you have a lot of catecholamine release, you have a lot of volume changes related to it, you have those coronary surges, you have a lot of different things that go on. So you might bring out somebody that's got a cardiomyopathy who has a family history of it, they would not be suspected of otherwise. So you want to be sure that you go ahead and do that in conjunction with it. Outside of really left main coronary artery disease or acute coronary syndrome, there's been studies that have looked at, people that are asymptomatic, should you do treadmills, should you go ahead and do interventions related to them. There's not been any data to show that that's beneficial, but if you do pick up acute coronary syndrome or left main disease, you really need to get the cardiologist on board if you suspect that and moving forward with it. Any new murmur that you hear, you want to be sure that you get an echocardiogram on them and have that evaluated. Low-risk patients and low-risk procedures, you really don't need to do a whole lot about. You don't need to do a lot of extensive testing, history, physical, and those sort of things related to it. But the point here being is be sure that you're aware of these cardiac risk factors and understand, if you have concerns about them, that you do appropriate testing upon them. The cardiac referrals, it just generally, whenever you have somebody who has poor functional capacity and you find them to have new murmurs and all these risk factors or these metrics are coming awry, be sure you reach out to the cardiologist and have he or she take a look at it, because I think that's that's very important. In terms of stress testing, the important thing to remember about that, if you do a treadmill on a patient, if they have a negative test, it's a pretty good sign they're not going to have problems with surgery. And so, therefore, the risk to them is like 0 to 4%. But if you do have, or someone comes across your desk and you see that they've had a perfusion scan and they got defects related to it, that has a high likelihood, obviously, of them having trouble after the surgery, and you want to be sure that you have that addressed with a cardiologist moving forward. The main thing to remember is that if you have people who've had coronary artery disease and have had bypass surgery, that if they have poor functionality, it's always good to intensify your workup with particularly echocardiograms and consider doing stress tests on them to be sure that they're at lower risk related to it. Another thing that you want to be mindful of, smoking. You want to be sure that these people stop smoking about 4 weeks at least before the surgery, because there is increased episodes of difficulty after the surgery if they have not stopped their smoking. The important point of all of this is to be sure that you get their risk factors under really good control before the surgery itself. So, whenever you do this stress testing, as I indicate here, if you have those large perfusion defects and you see that, you want to be sure that you get them to the cardiologist. The other thing in terms of there's a lot of consideration about a use of beta blockers, and there is mixed results in terms of whether you should use beta blockers before surgery. But if you have someone that is going into high-risk surgery and they have a lot of risk factors, particularly if they've had coronary artery disease in the past, you certainly should consider the use of those beta blockers before that surgery, as well as it has been shown to be beneficial in terms of decreasing the events after the surgery itself. In terms of medication, when the certain drugs you need to consider preoperatively, if you've got them on an ACE inhibitor, an angiotensin receptor blocker, it's probably not a bad idea, as well as diuretics, to hold that on the day of surgery, because they have a lot of volume shifts. A lot of them may have trouble with renal insufficiency and things afterwards, so it's advisable to do that. Likewise, there's a lot of literature now showing that if they're on SGLT2 drugs, when they're on that, it's a good idea to hold them for 3 days before their surgery. And if you have to, you can use sliding scale insulin. There has been some increased instance of diabetic ketoacidosis if you continue the use of those drugs and they become hypovolemic. So you might want to bring into consideration of that whenever you're thinking through your drugs. There's a lot of talk about the use of NOCAs, Eliquis, et cetera, what you should do related to that, because a number of people are on that. If you've got minor bleeding, if there's risk of minor bleeding, then what you do is you hold the drug the night before surgery or the day before surgery. If it's an intermediate risk of bleeding, then you hold it again. You again hold it for the day prior to it. But if they're high risk for surgery, you'll want to be sure and hold that Eliquis 2 days prior to the surgery and generally start back about 48 hours afterwards, assuming that their bleeding is under control. So look at the Eliquis, the Nokus, be sure you're aware related to that. There is, with surgery, you'll run into this, and this is really a tricky issue, and that's if they've had coronary artery stents put in. As you well know, that what happens is with the bare metal stent, they'll endothelialize at about a month. With the drug-eluting stents, those stents don't endothelialize till about 3 months after you put the stent in. So with the current thought is that you continue dual platelet therapy for 6 months after the drug-eluting stents put in for people who have acute coronary syndrome. People who've had myocardial infarction, it's a year. So the important point here is if you get into these use of these dual platelet drugs, you need to touch base with the cardiologist, because obviously the preferred thing would be to wait a year after the stent's put in because of the risk of the stent closing down. But most importantly is that you possibly could get there with it in 6 months if it's acute coronary syndrome, but if they've had previous myocardial infarction stent been put in, it's a year. So you really need to work closely with your cardiologist on that. If something comes up that's urgent that needs to have surgery, obviously you'd like to delay it as long as you can in relationship to it. Now the question is controversial, and certainly the cardiologist and probably hematologist oncologist involved in it, but sometimes you have to do surgery and they pull them off of it. Sometimes they'll keep them on aspirin, but I would not go into that area if they're having problems that need surgery and they're within those time frames of 12 months or 6 months. You really need some help going forward on that, because they could really get in trouble with that clot slowing down on that. The other thing that you need to realize that if you've got a mechanical valve in, if you do a mechanical valve and they're on, say, a warfarin, which most of them are on, you want to hold that warfarin for 5 days prior to the surgery. With that, you'll need to bridge them. It's the only example where you need to bridge them. So you bridge them through using Lovenox, et cetera, related to it. Here again, I'd work closely with your cardiologist and be sure that you're on tap when you do that, because that can be an issue. Another issue that comes up whenever you encounter these patients, a lot of them have defibrillators. And if you get into those defibrillators, a lot of times they have to go to surgery, and as you well know, that can pose a problem if there's a lot of MRIs or tests that are done with that. Be sure that you talk to the electrophysiologist how to handle those things, because a lot of times if they have to go to surgery and they have the defibrillator, they often turn those off, but have to have the AICD rather, and they have to have those judged. Look very carefully whenever you have a patient that's going to surgery who has a AICD in place, and correlate that very closely with the cardiologist. The other issue that you don't often come in touch with, but you want to be real careful about, is somebody that has pulmonary artery hypertension. So someone that has moderate or right ventricular dilatation and dysfunction, those people get into real trouble post-operatively. So if you see that, you see a report of pulmonary artery hypertension, that's where you want to reach out to the cardiologist, the pulmonologist, to help you monitor that. The other thing that you get into is looking at the problems with pulmonary complications. So the things that you look at here for people that can get into trouble with are those ones that have had congestive heart failure, COPD, cigarette use, have had the type of procedure that they have where they have abdominal aneurysm repair, thoracic surgery, upper abdominal surgery. So those are ones you want to be sure to get a chest x-ray, EKG, and if they're going to have lung resection or surgical coronary bypass, you probably need to have pulmonary function tests on them. But certainly those are people that you want to jump in if they have problems related to pulmonary post-op pulmonary issues, to touch base with your pulmonologist. It's a good idea if someone has COPD and a very dyspneic before surgery to do arterial blood gases on them, because often you might pick up hypercapnia. And don't forget that these people that have sleep apnea, you want to be really careful and check them for sleep apnea, because a lot of times they can get in real trouble post-operatively if you don't identify that, and you want to be sure that you pick that in your history and physical as you move forward on it. The other issue that sometimes you run into is people who have cirrhosis or liver disease. You do not want to do surgery, obviously, on somebody who has decompensated liver disease or acute hepatitis related to it. What they use is something called the MEL score, and it is a measurement for end-stage liver disease. And this is it's compiled by looking, as you can see at the bottom of the slide, on the basis of creatinine, bilirubin, and prothrombin. The problem with liver disease, often you have hypotension, and these patients do not tolerate that very well with cirrhosis. One of the things you want to look at, if anybody has a MEL score over 15, no surgery. They cannot have that surgery if they're over 15 because they're really going to get in trouble, and the mortality jumps up to about 70% whenever you see that. So if you see a MEL score greater than 15, and here too you'll want to have your gastroenterologist or hepatologist involved in this, and you also want to be mindful to remind the patients if they do have cirrhosis that they can get in trouble with renal failure. You'll also want to review too, have they been on beta blockers? If they've got varices, etc., you want to be sure those beta blockers are continued post-operatively. Also review if they've been scoped recently, if they have ligation of their varices, when was that done? Is there concern about that? Be sure you get them stabilized if they've got any evidence of liver disease before they go into surgery. The other thing is don't forget to discuss with them DVT prophylaxis, and because that incidence of pulmonary emboli is really an issue. Unless they're having surgery that requires less than 30 minutes and they're mobile, most of these people are going to need DVT prophylaxis. So you want to go over, discuss with them, preoperatively when you're evaluating them, what's going to be needed to be done post-operatively about their anticoagulation to keep them from having pulmonary emboli. This points out again the issues that are related to increased risk of venous thrombosis, and you can look through that. You want to go over those things whenever you're doing your history and physical and see if any of these areas like myeloproliferative disorder, if they've had pelvic radiation, if they've had a stroke, they're over 60 years old. Be sure you identify those risk factors in your history when you do them preoperatively. The other thing, too, is to also remember on some of these really frail patients, one of the things, the second indicator of poor outcome is nutrition. So some of these real frail people, you want to get a prealbumin on them. If their prealbumin is very low, that's the second most disastrous, or the indication for disaster. So be sure you monitor their nutrition, and on these real frail people, if there's any question, check a prealbumin, look at their nutrition, because you may want to address that, particularly if you have time to push forward on it. The other thing I think also need to be mentioned is from an endocrine standpoint, and you often forget this. If anybody's been on 5 milligrams or more of a steroid, for say prednisone, for more than 2 weeks, and they go into surgery, they can be at risk of adrenal insufficiency. And so this is something you need to monitor, because all of a sudden post-operatively they're crashing and burning. It may have been that they've been on steroids, and so therefore you want to look at that, because you may want to post-operatively give them solumedrol and be sure that you cover them for several days, bring up their oral dosage and taper it down. But be sure that you don't get in a problem with adrenal crisis on the basis of them being on prednisone and you missing that because you've been treating them for a period of time with their prednisone. The other thing too is also remember that people have hyperthyroidism. You want to be sure you get that under control, because these people can go into thyroid storm. So you want them euthyroid. If you can, you want them euthyroid unless it's just an urgent business that they're at risk. You want to be sure you get their hyperthyroidism under control before you send them to surgery. If you don't, thyroid storm is a really tough problem, and it could be very detrimental to their outcome. And it's also important to remember too that you want to be sure you keep their blood sugar in range, generally somewhere between 80 and 160. If they're over 200, you need to get that blood sugar under control before you send them into surgery, because they're going to have some problems related to it. Interesting, hypothyroidism is less of an issue unless they got myxedema. So if they got hypothyroidism, you could probably work through that. But you do not want anybody going to surgery that has hyperthyroidism. I guess the meat of this is that you want to be sure you do a good history and physical. You understand the procedural risk. You understand the patient-specific risk. That you understand their functionality, their ability able to tolerate surgery. You especially want to understand their cardiac risk and also mitigate those issues as much as possible. You want to be sure that when they're going to surgery, that you communicate with your surgeon and the whole team, the cardiologist, pulmonologist, that everybody's aware of those, because a lot of these people are so specialized, they're focused on their particular system. And they're depending on you as the generalist to be aware of their thyroid, to be aware that they're on prednisone, or be aware that they've had trouble with nutrition, etc. So it's paramount that you do a good preoperative evaluation, good history and physical, make the patient and the team aware of these risk factors in order to make it such that they have a successful outcome. Thank you.
Any questions for Dr. Leahy or Dr. Peacock? All right, we've got just a couple minutes for a break. All right, guys, we'll go ahead with our next presenter. Dr. Hannah Stewart is a native of the Appalachian Mountains of Southwest Virginia. She attended Appalachian State University from 2009 until 2013 as a pre-med majoring in psychiatry. She received her osteopathic medical degree from LMU-DCOM in 2017. She completed her internal medicine residency in Morganton, North Carolina, where she found her passion and desire to care for the underserved older adult population. She completed fellowship training in geriatrics at Vanderbilt University in Nashville, Tennessee, where she experienced many different care settings for older adults and the need for education regarding this population. She became an assistant professor of medicine at Vanderbilt, where she worked directly in the acute care of the elderly unit. During that time, she worked directly with resident doctors, medical students, pharmacy students, and nursing students, teaching geriatric principles. More recently, she returned to the place she calls home as a hospitalist at UNC Appalachia in Boone, North Carolina, where she has witnessed the need for geriatric care and education in this region. She is excited to help make the hospital more age-friendly, teach students about geriatric care, and work on more community involvement. Please help me welcome Dr. Stewart.
Is this the button? Where's
Green clicker right there that'll move you forward.
just that? Okay. All right. Hi. Of course, they saved the coolest topic for the last day, geriatrics. So today I'm going to be talking about approach to a patient with cognitive complaints, dementia, delirium, and depression in the older adult. I like to say, I don't like to use the word older adult. I like to say vintage, seasoned, or experienced. So I'll take recommendations after if anybody else has anything. So I have no disclosures. So obviously, we have to start out with a meme. Very true. So my objectives today are to identify neurological and psychiatric disorders that can cause cognitive complaints, describe indications and components of neuropsychological testing, recognizing the characteristics and features of the most common types of dementia, and then comparing and contrasting mild cognitive impairment, dementia, depression, and delirium. So we're doing all the things. So first going to just kind of talk big picture here, and we're going to kind of dive into each one of these. So what are the differences between normal aging, mild cognitive impairment, and dementia? So we all do it. We have put the cereal box in the refrigerator, you lose your keys, you do these things. That's okay. A lot of times that's normal aging. So we say it's mild cognitive impairment when you do have these objective cognitive impairments, but it does not affect your activities of daily living, your ADLs, which we'll kind of go through in a bit. And so then we go to dementia, which per the National Institute on Aging dementia is the loss of cognitive functioning, thinking, remembering, reasoning to such an extent that it actually does interfere with these activities of daily living. And it's really hard sometimes to really distinguish between these. So we'll kind of dig in on ways to approach it. Come on. All right, so somebody comes in with memory complaints. Usually it's super vague. A lot of times, it is like that. I'm forgetting where I put something, having word finding difficulties. And so we have a huge differential. And so our differential is obviously the normal aging. Polypharmacy and medication side effects are huge in this population. The mild cognitive impairment, dementia, depression, metabolic disorders, and toxins. So where do we even start? So history is the huge thing, and we'll dig into that. Your physical exam, labs, imaging, cognitive testing, and psychiatric testing. So hopefully y'all can see, okay. So history really is one of the most important things. even if you are concerned that a patient has dementia, do not talk over them or act like they are not in the room, because that can be extremely embarrassing and cause people to kind of close themselves off. So it's really important to make sure the patient feels included, and then also get out of the room, or would you want me to call them while you're in here? And then always asking first. And then what questions to ask. So some big ones are, how long have you been having these symptoms? What actually are the symptoms? So memory, language, executive functioning, and then behavior or personality changes, and then neuropsychiatric changes like hallucinations, delusions. So some specific history questions. So again, their functional status, their past medical history, comorbidities, medications. Do not forget over-the-counter supplements, and be very specific. I have people come in, they're like, I'm just taking Tylenol, and it's Tylenol PM, and so it's Tylenol with Benadryl, and so they are all over the place. And then they love some QVC in the long-term care facilities, and they will buy some stuff. And I'm like, I have no idea what's actually in that, and it can cause a lot of symptoms, but QVC is good and bad. And then family history, especially cognitive and psychiatric. And then depression is a huge one, which we're obviously going to dig into. And then alcohol use and drugs. I think that we think as people age that they don't partake in that, but I mean, it happens. I've had several patients I had an 88-year-old using crack cocaine. And I mean, it's not something you would ever think to ask, but it really is important, and normalizing asking these questions. And then asking about what support they have. Is it family? Do they have caregivers, friends, social activities? Do they go to the Y, or have a church family, things like that. So starting out with function. So we have our IADLs, and those are kind of, most of the time if people can do their IADLs, they can do their ADLs, but it is important to go through all of these. So those are your medications, shopping, meals, household chores, your phone, computer, iPad, and then finances. And then you have your ADLs, which is more basic. So that's bathing, dressing, feeding, continence, toileting, and transferring. And so you really want to compare to their previous function and when and if anything has changed. Sometimes you'll see where people, okay, so somebody will say, I've never cooked, or I'm not cooking. And I say, well, could you if you needed to? Or could you drive if you needed to? So then we kind of go into labs. These are my routine ones. So I usually do just a basic CBC, CMP, TSH, B12, and vitamin D. And obviously, if you're concerned for a specific cause like syphilis, HIV, or heavy metals. One big thing to look out for on labs for B12 and vitamin D is sometimes it's easy when you're seeing a ton of patients, especially in the clinic, to just look at the red numbers, but sometimes the B12 will say it's normal, but you actually want it above 400 in an older adult. And then sometimes vitamin D will, some weird reason, say that above 20 is normal, but you really want it above 30. So actually really taking a look at those numbers. And then another, I think it missed a slide, but that's okay. There was one on imaging, but it disappeared. Well, for imaging, I'll just tell you, really is not that helpful. Sometimes they'll use an MRI or CT, but usually that's people that are younger, have really fast progressing dementia, and then sometimes a PET scan in research, but they're really, really expensive, so. All right, so for our neuropsych evaluation, we have our cognitive screens, behavioral observations, emotional screens, and intellectual functioning. So our big one is depression, which we should be screening in everybody, but risk factors are female comorbidities, functional cognitive impairment, uncontrolled pain, widowed, divorced, and social isolation. Nursing facility residents have much higher rates of depression. You are really isolated. We saw during COVID, it was awful because you just really have almost no access to the outside world, and a lot of people had significant worsening of their depression. And depression still is a risk factor for suicide in older adults. And it's often hard to rule out dementia if a patient also has depression, you know, the pseudo dementia. So teasing that out and trying to treat the depression prior to doing your cognitive assessment is really helpful. So what tests do we use? The single best one is just, do you ever feel sad or depressed? It takes 2 seconds to ask in a clinic. It's a yes or no, and if it's a yes, then you can start digging in. But you should be asking this every visit. And then the PHQ-2 is also a very quick one that should be asked in every patient greater than 65 at a visit. So that's just over the last 2 weeks, how often have you been bothered by any of the following problems? So little interest or pleasure in doing things, feeling down, depressed, or hopeless. Then we also have the 5-item geriatric depression scale. So that's just a yes or no. So that makes things, we try and make things as simplified as possible. So it's a 0 to 1, you're not depressed, and greater than 2 is depressed. And then we have our generalized anxiety disorder, which I think most of us know about. And then one that is most often used in like the neurology or geriatrics clinic is the Cornell Scale for Depression in Dementia, and that actually allows for observers, so family members, caregivers, to actually give their input. Because sometimes, especially if somebody's nonverbal, you can't just ask them a yes or no question. So, cognitive screening test. So our mini cog, I'll show a picture of it in a minute. It's really quick and easy to do in the office, to do in the hospital, wherever. And we also have the MMSE, which is a much longer test. And it is difficult to do these tests in primary care because you have very limited time. And so understandably, being able to refer to geriatrics or cognitive assessments, screening in other resources in the community. Where I'm at in Boone, North Carolina, we have a whole Aging Well clinic where it's free, and they'll do a whole aging assessment. And it's great. They have hours they'll spend with them and decide what services they need to refer them to. I don't know if there's anything like that where you all are, but it's something to look into, especially if it's free. The one in North Carolina, if you do Appalachian State Aging Well assessment, and it'll pop up, and all the patient has to do is call them, and they'll set it up for them. And then we, of course, have our MOCA, which is the one that we use most often. So here is our mini cog, very simple. So you ask the patient to remember the 3 words now and later. Please try and remember them yourself, because I try and use the same ones every time because it's actually harder than you think. And then you want to ask the patient to draw a clock, and then after the numbers are on the face, you want them to do it to read 10 minutes after 11. Then you ask them to recall the words. And so you can see it's 1 point for each word recalled, and then it's an all or nothing for the clock. And so I'm sure if you all have done these, you have seen some very interesting clocks, and there's one, the MOCA has a block, and you never know what you're gonna get. But you need to have 4 out of 5. So pretty much you can miss 1 word, and that's it. Then we have our MOCA. So I'm sure you all have seen this before. It's time consuming, but this is often what we use. The VA does a SLUMS test, which is very, very similar. And so this if you have had less than 12 years of school, you also get to add a point. And there's a lot of debate on what we consider severe dementia based on just the MOCA alone. They say that greater than 26 is normal, but again, I feel like nobody's great at figuring out what exactly they would consider severe dementia. Never mind, here's the imaging. So again, kind of what I just said. So now we're going to kind of break these up. So normal aging, those are just the deficits that don't impair function. They're stable over time. You get slower processing information. It just kind of is what it is. And word finding difficulty is very common. And then mild cognitive impairments. Again, we need the memory complaint with one impairment in one or more cognitive domains. It does not cause that interference with daily life. And you do have increased risk of Alzheimer's disease. So now we're going to talk about dementia. It's a huge umbrella term. It is really hard often to distinguish. People are like, well, what type of dementia do I have? It's really hard sometimes to distinguish unless they have these really, really characteristic pieces of certain ones. So we all know that Alzheimer's is the most common, and then we'll kind of, but a lot of people are that mixed dementia. So Alzheimer's disease is the most common. It's typical over the age of 60, 65. Usually early onset is what we would consider less than 60. And that's often people come in complaining about their job performance or, hey, my boss has been getting on to me a lot lately. There's the inherited rare form, and then that's consistent with memory impairment, executive function and judgment problem solving, behavioral and psychological symptoms, and then your risk factors. Huge one is family history, being female. That's great. And I accidentally put female in there twice, and that was a mistake, but here we go. Age, hearing loss, and then social isolation. So I just kind of wanted to throw this in here. I've used it many a times. This is the FAST scale. So when I've found it most beneficial is when family members or caregivers are having a really hard time and very frustrated that, you know, my husband, why is he acting this way? Why is he having incontinence? You know, why is he's embarrassing me, things like that. And so I pull this up and I go to them and I say, hey, okay, their mental age is like a 1-year-old. And sometimes that makes something click in their brain that they're like, wow, you know, I need to give them a little bit more grace and myself some more grace. And then also the other way to use this is to be hospice eligible only through dementia, you need to be a 7C. Sometimes it's hard because people are kind of in between, and especially for hospice, you can kind of work with that. But I really like this tool and use it often. So then we have our vascular dementia, which is the second most common type. Again, often very difficult to distinguish between Alzheimer's dementia. So our risk factors are the same for like a stroke or heart attack. So your high blood pressure, your diabetes, high cholesterol, tobacco use, age, low physical activity, and coronary artery disease. So we have that post-stroke dementia, which is really stepwise. And I mean, the steps sometimes are very significant. They're kind of cruising and then boom. I mean, it's a significant change. And a lot of them have neuropsychiatric changes like depression, psychosis, delusions, and hallucinations. Post-stroke patients often already have that depression, and it really does come out as some memory issues as well. Then we have our Lewy body dementia. So that's kind of an umbrella term for Lewy body dementia with Lewy body and Parkinson's disease with Lewy body dementia, which is a mouthful. So in dementia with Lewy body, the dementia starts before the Parkinson's symptoms. And so it's dementia with at least 2 of these core clinical features. So you're going to have the fluctuating cognition with pronounced variations in attention and alertness, the recurrent visual hallucinations that are typically very well formed and detailed, are REM sleep behavior disorder, which is the acting out of the dreams. I had one the other day, and I mean, he had been having this for a while and having cognitive decline, and the family had never thought to mention it. She thought it was just bad. The wife thought it was bad dreams. And then one or more of these cardinal features, so of Parkinson's, so the bradykinesia, resting tremor, rigidity. And then they often have severe reactions to antipsychotics. They'll come into the hospital very agitated, get some Haldol, and they will be climbing the walls. Then we have our frontotemporal dementia. So that's usually younger men. And so that comes in with this disinhibition. So I had a guy who ended up giving all of him and his wife's money to a scammer on the phone. It got so severe, she had to take away his phone, his tablet, his computer. She gave him a landline, but I mean, that's what he did all day. And then, you know, they're can be hypersexual, and it can, again, trying to help the family members understand that it's not they're trying to be inappropriate, that this is a disorder in their brain. And then they often have the apathy, loss of empathy, the hyperorality. They can binge eat, love sweets, alcohol, tobacco, and often have those compulsive behaviors, kind of like a OCD. So, okay, y'all can see that. So with frontotemporal dementia, we kind of go down two sides. So you have that behavioral variant, which is the changes in the personality and behavior, and that's the one that I've seen most commonly, and that's when the frontal lobes are affected first. And then you have that primary progressive aphasia, which kind of goes into those other two, the progressive non-fluent and then the semantic dementia. So I just love to throw things randomly in that I feel like don't get talked about enough, especially when we're talking about dementia. I think we often forget about our caregivers. Caregiver burden is real. I'm sure most of you have seen it. So driving, wow, that is one of the biggest issues I've come about. People do not like their driving taken away. They will keep those keys, they will hide those keys. And so I often try and put the heat on myself and take it off of the caregiver, and like, no, I'm telling you, you know, you can't, I know you can't really say you can't drive because that's illegal, but saying like, we really don't, it's me, it's not your family that's telling you not to drive. And then you can refer to OT for where they'll do testing to where they can actually legally take their license. Money management, again, is a big thing. Having early oversight, and then medicines. I'm sure you all have seen people come in with a baggie and it's just a bunch of medicines mixed together, and they're like, no, I know what color my pills are, and they never do. And so getting a pill box, and if, you know, say if my husband had dementia and they were getting frustrated, like, why do I have to use a pill box? Just use a pill box with them. Say, let's do our medicines every Sunday. You know, I'm having a little trouble with figuring out what I'm taking, why I'm taking it. Let's do it together. And then some pharmacies will do pill poppers, which is really nice, where, I mean, they do them for you. They just have to pop them out. And then housing. This is a huge financial strain that we face every day because skilled nursing facilities, long-term care facilities, independent living, assisted living, it's expensive. What I do recommend is planning early, talking with your loved ones that are aging about, especially insurance. So anyone over 65 should have Medicare. And I always think of Medicare, the E. I hate the word elderly, but E for elderly. So anybody over 65. And then obviously Medicaid is income-based, but really pushing, if somebody can get Medicare and Medicaid, that is the best insurance. And not having these insurance companies scam them, because some of these advantage plans give negative advantage. So talking about that early. And then again, caregiver burden. So in North Carolina and Tennessee, there's the Alzheimer's Association. So I sat in on when I was in Nashville, the Tennessee Alzheimer's Association. For people with dementia, they had one was called the Memory Cafe, and this was when COVID was going on. And so it was people that had the diagnosis of dementia. They could come on Zoom, and it was awesome. You know, one was a prior physician, and he would ask the group, like he said, you know, I'm struggling with this. Has anybody been through this? What did you do to get through this? And then they had a caregiver support group, which was awesome. People cried, people laughed, you know, because you're going through a tough time, and especially when we had all of that isolation. So trying to figure out what resources are in your area, and there are national resources. So another one that I feel passionate about is advanced care planning. There's no time that's too soon to start talking about this. So making sure that people know the difference, that just because somebody is your power of attorney for your finances does not mean that they're your power of attorney for healthcare, having a living will and advance directives. And then it's a lot easier. I work only in the hospital right now, and it's difficult to have these conversations about code status in a 98-year-old with dementia that's full code, that it's never been discussed. Because I've only met them once, it's a blip in time. So trying to have those conversations by their primary care provider makes everything a lot easier. And then this is just a quick blip on capacity. So competency is by the court system, but we can do capacity. And so I'm getting low on time, so there's capacity, if you can look up a chart for it. So treatment of depression and anxiety. So what I usually do in older patients is I say, are you feeling a little more anxious, or are you feeling a little bit more depressed? If they are feeling more anxious, escitalopram or Lexapro is usually my go-to. You can titrate it up really quickly. Patients tolerate it really, really well. If they're more depressed, sertraline or Zoloft is my go-to. It is pretty much the only one that's not going to prolong your QTC. It gives them a little oomph, and so Zoloft is a great choice. Citalopram I don't use as often because you cannot go above 20 milligrams in an older adult. Fluoxetine, which is Prozac, is really good for if you have one of these hypersexual patients with dementia that are acting out. You can give them Prozac, and it works wonders. And then paroxetine, please do not use, which is Paxil in an older patient. Anticholinergic, I do not use it. And then here's just kind of a list, this is from Up to Date, of things I do not use. I do not use SNRIs because the coming off of them is impossible. Duloxetine with pain is good. And then trazodone for sleep is great. And then mirtazapine or Remeron I use in patients that are having weight loss and difficulties with sleeping. You do not go above 15 milligrams for the mirtazapine, though, because you start to actually lose some of that appetite stimulation. I have no idea. Maybe pharmacy would know. And then TCAs are a no-no, absolutely. So treatment of dementia is terrible. We do not have any good options pretty much. So and it's only approved if they actually have moderate dementia, but we see Aricept, donepezil prescribed all of the time, and we actually just end up seeing the side effects from them. So donepezil, which is Aricept, has terrible GI side effects. They have bradycardia, and usually they're all on a beta blocker, and so they'll come in with a heart rate of 40 and wonder why they're falling. Sometimes when titrating it off, you can get a little agitation, so you just have to be careful with that and look out for that. And the other one we use is rivastigmine. It is a patch. It doesn't have the GI side effects, but again, I just still don't feel like it works as well as anything. So we also have memantine, which I I think there's a huge placebo effect, and some people do not want to come off of it. So if you can say, hey, well, your heart rate is so low, that's why you need to come off of it. And then there's some new medicines that are the monoclonal antibodies. They are really, really expensive and have very little research. So my favorite topic is delirium. So the reason we really care about this, especially in the hospital, you have increased mortality, hospital complications, falls, infections, ADL dependence and long-term function impairment, institutionalization, a ton of them discharged to nursing facilities, all of the things. And so 75% of us will actually miss this if we don't use a validated tool. So our predisposing factors are kind of just what you would think. So functional impairment, age greater than 75, depression, alcohol use, and sensory impairments. So everybody loves a mnemonic. So Dr. Dre pinched me is one. And so these are delirium triggers. So it can be any and everything. So the big ones are medications that I see, and then drug removal, diseases, again, kind of everything you could ever think of. So what we use in older adults in the hospital is the BCAM. And so for this, you see that you have to have this number 1 and number 2 positive, and then either 3 or 4. So number 1 is super easy. You're gonna have the nurse or a family member, caregiver saying, they're just more confused. Like, can you come take a look at them? So that's kind of what triggers this whole thing. Then you have the inattention. So can you name the months of the year backwards from December to July? And some of them will just say, oh no, I'm not even gonna try, and that's okay. I really like to normalize asking these questions too. Do not say, I'm giving a test, because then if they don't do well, they're like, I failed, I'm embarrassed. So I just say, hey, let's just chat. I talk about this with everybody. I was like, I got a tough one for you today, and just kind of really making them feel comfortable with this. Another one you can do if they are nonverbal is the save a heart. So you say, every time I say the letter A, I want you to squeeze my hand, and give them a practice round, because especially if they have Parkinson's or something like that, they can be delayed. So seeing what their A squeeze is. And so you just say SAVEHAHAART, save a heart. You can add in some A's. And so after that, so if you have both of those, then you can look at 3 or 4. 3 is also easy. A RAS, anything other than 0 is positive. And then the disorganized thinking, you have to say these are yes or no questions, because they will say, well, there is a stone that floats on Mars. So really saying these are only yes or no. So treatment, again, this is just another mnemonic, so homies. So big ones, hydration and nutrition. Often in the hospital, you'll walk into a room and their dinner tray is across the room. How are they supposed to get up and get it? They're not able to feed themselves, so making sure if they need assistance, that they will actually have that assistance. And then they also have those that you can order on Amazon that have the bigger handles to feed with, and those are really nice, especially in post-stroke patients. Orientation is a big one. We are blessed where I'm at now to have the boards that are electronic that have the correct days, but the whiteboards are always wrong. They'll say it's from 4 days before. It'll be the wrong team of providers, and so making sure and telling families, really engaging them and telling them, hey, what you can do is reassure the patient. Today's date is blank. This is what happened. You're at this hospital. Everything's okay. Mobilizing them, getting them up, getting PT, OT involved, managing their pain. We love some topical stuff, and I love just scheduled Tylenol, because often these patients can't verbalize the pain. And so you're really relying on some of their nonverbal movements. Minimizing their medicines, eliminating devices. You know, you walk in and you're like, why do they have a Foley in? Oh, well, it was put in by the ER. So trying to get that out if you can. Again, engaging family. Using eyeglasses, hearing aids, and trying not to do vitals like Q2. I'm working on a delirium toolkit that will have hearing aid batteries, even denture cleaner, the paste. I mean, simple things that really you don't think about if you don't have hearing issues, because it can really trigger that delirium. And then, of course, polypharmacy. Deprescribing is a lot of fun. So a new symptom in an older adult is often the side effect of medication that we have done. And then it kind of gets that trickle if we just keep going and going. So if you look, MedStopper, if you Google MedStopper, it is an awesome, awesome website. So you can go on, the first thing it asks is the patient frail and elderly? And so if you click yes, then you can type in all of the different medicines, and you can it will tell you like everything you need to know, how to titrate it down, what withdrawal symptoms are, and again, which one to start first. One big one, again, with the TCAs is you would be surprised to see that in an older adult, you want to discontinue amitriptyline before Ativan. So that tells you how bad TCAs are. And then we have the Beers criteria. I don't know, I guess somebody's name was Beers, but that is kind of a list for potentially inappropriate medications in the older adult. So medications for delirium. We obviously don't want to give medications unless we have to, but these are the safer ones. So melatonin, as we age, our melatonin decreases anyways. So everybody takes it wrong. They take it right before bed and they're like, it doesn't work. So taking it 2 to 4 hours before bedtime and actually asking patients when their bedtime is, because sometimes it's 5 o'clock. Trazodone is another one, and the reason I'm putting this in here, and I do use it for delirium if they're having agitation and they're able to take a pill, because you don't prolong the QTC, and nursing facilities for rehab will not tell you that they will not accept a patient because of them being on an antipsychotic, but that's why they may not accept them, because they get dinged by the state for having too many people thinking, oh, they're just knocking everybody out down there. And so it actually works really well. Then benzos, so with your alcohol withdrawal, Presidex is awesome, but you have to be in the ICU and you have that risk of bradycardia. And then Depakote. Depakote was another that wasn't getting dinged by the state, but this year I think is going to be added to the list. So, but it still is nice because you can use it IV, you can use the sprinkles. Sometimes when you have these they almost appear manic dementia patients, it works really well. And then here's our antipsychotics. This is really the only reason you go to these is if they're a harm to themselves or others. And you do have to tell family members that there is a black box warning for cardiovascular death in patients with Alzheimer's dementia. So kind of starting at the top, Haldol's the one everybody reaches for. It's pretty easy peasy. The issue with older patients is people will give 5 milligrams when they should do 0.5 to start with. I'm like, hey, we can always take back, or we can always add on, but we cannot take back. And so I usually, do the 0.5 to 1. And then Abilify is awesome. It is the least anticholinergic, but it's not good in the acute setting. But in the outpatient setting, it is great. It just takes a while to really work. Zyprexa, also love because you have the ODT, but also starting low at 2.5 milligrams. Seroquel, for if they're not sleeping, is great, starting at 12.5 milligrams. I don't use Risperdal much, and I definitely don't use Geodon in our older patients. That could go really badly. And so here's just my fun checklists for rounding. So always looking at their cognition, doing that mini cog, looking at what their baseline function is, looking at their devices, what all's hooked up, drugs, their advanced directives, trying to estimate when they're going to get out of the hospital, and then actually talk to the family and the other parts of your team. And then my favorite thing is the top 10 signs you need a geriatrician is you think the beers list has something to do with happy hour. Yeah, so there's just some resources as well. And so kind of the key points here is that normal aging can be differentiated from cognitive impairment by the impact on ADLs. I've said it 100 times, I know. And then history is really one of the most important components of when somebody comes in with these memory complaints. Labs and imaging sometimes are just not very helpful, and so really prioritizing, because you don't want to have this huge cost when you could make a clinical diagnosis without these things. Screening for depression, and then there are a lot of screening tests, but the mini cog is the easiest one, that especially in a primary care clinic. And then dementia is an umbrella term, often those overlap. Advanced care planning should be discussed early, and don't miss delirium in the hospital setting, and treat with non-pharmacological measures. Don't treat a side effect with another medication, and always ask what matters most to a patient. They call me the meme queen. Nobody has ever called me that, but I just gave it to myself. Does anybody have questions? Yeah.
Normal pressure hydrocephalus, that's the differential. You didn't mention that on the you probably want, if someone has incontinence and dementia in the emergency department, I've seen that, and get a CT scan to rule that out.
Yeah,
So,
for
as a
sure.
differential, So,
Yeah,
yeah.
absolutely, absolutely. Oh, come on, no questions? No questions? Oh, you've got a question. Oh, I was like,
Have you seen the different forms of mochas that are out?
no. There's new ones?
I will show them to you.
I prefer the old one.
So they have different animals and different things you have to draw. Instead of a cube, there's a bed or a chair.
There's two different ones that have been around for a while. I'll take a look.
Okay. Just as a plug for all of us primary care providers out here, we should be doing a mini cog and asking about advanced directives with every Medicare wellness visit. My next question for you. What are you using as treatment for hallucinations outside of Lewy body dementia?
Yeah, it's really hard. So I oftentimes will use an SSRI. I feel like they all need to be on an SSRI. And then sometimes I'll use the trazodone, or sometimes I'll use Depakote. Those are ones that you really hate to reach for a benzo. I usually never, especially for delirium in the inpatient setting, reach for a benzo unless it's alcohol withdrawal, or if they're Parkinson's patient, which you could try Seroquel, but Seroquel you give oral. But that's the only other time I would use a benzo is in a Parkinson's patient as well. But yeah, I mean, trying anything it's usually a trial and error with those patients, but I've had great luck with trazodone. I mean, and people are like, oh, you can only take it at night. No, you can do that 25 Q8. You can keep titrating up. So. Yes.
You mentioned assisted living facilities and Medicare and insurance and caregiver fatigue and all of those things. So with the caregivers that are having fatigue, is there a good one is there a good way to kind of get them into an assisted living if they need it? Or with insurance, have you?
Yeah, so oftentimes, if they're admitted to the hospital, even if they are, between insurances, you have to have either a 3-night stay or have a reason to be inpatient. It's a lot easier to do it from the inpatient setting, but you can probably speak towards outpatient. There are social workers, case managers that Yeah, in some places we'll cover respite care, but it's really hard to get people into a SNF without having gone to the hospital. I mean, it really is, which is really unfortunate because it causes a lot of tension in families, especially in like the Appalachian region. People want to age in place, and so families are stuck, you know, with their grandmother that's like, I'm not leaving the house that I was born in. And so and then they fall and no, you're good.
Like a second point to that is I've had a lot of elderly that, you know, it's kind of like the saying, the blonde leading the blonde. Like you'll have a married couple that's elderly and you'll have one that's kind of healthier that's taking care of the other one. But if the healthy one has to go to the hospital for something and then the really unhealthy spouse is, you know, completely dependent on that spouse for their care and they're left at home, you know, I've had them tell me, I can't go to the hospital. I can't go to the hospital because I can't leave my spouse that's, you know, dependent on me. So,
Yeah.
I mean, any suggestions for that type of respite care and getting that?
This is what I've done is I've reached out and tried to find, like, again, the Aging Well Clinic, what resources are available. One big thing, again, I've seen in the Appalachian community are churches. It doesn't matter if you go to that church. It doesn't matter if you are religious, but they will really help out their community. And so that is one place that I've seen is very helpful, especially with transportation, things like that. But it's tough. I wish there were more things, and that's why I think it's important because if we're lucky, we're all going to get there someday. And so trying to really advocate for these people that we need more things. Yeah, and home health can come in, and that's easy to get in. They don't have to be hospitalized to be able to try and get some home health services and physical therapy at home. It just needs to be in order.
One thing to not forget, it's been very useful to us, is make sure whether your patient is VA eligible. Because, I mean, VA pays my daughter full-time to stay home with my dad, and they send a social worker out, and they provide lots of supplies, and they really help with the caretaker fatigue too. So
yeah, that's a great point. Yeah, they do the homemaker services. Like, I mean, it's great. So. All right, it's been fun, guys. Happy Father's Day to all the fathers. All right.
Stuart. A short get started right at 11. All right, guys. The next presenter is Dr. Gina DeFranco. If you are affiliated with DCOM at all, you know Dr. DeFranco has been with them for a long time. I think she put one of the last bricks in the building. But she currently serves as the chair of family medicine at LMU-DCOM. Her academic responsibility is primarily direction of the clinical skills course for the first and second year medical students, while also managing the adjunct faculty program for on-campus activities. Dr. DeFranco's research interests include empathy and communication, as well as provision of feedback in early clinical settings. Her clinical focus is hospital medicine in a community hospital setting, as well as precepting students at a local free clinic. She's the past president of the Tennessee Osteopathic Medical Association and continued activity as a delegate to the AOA House of Delegates for Tennessee. Please help me welcome Dr. DeFranco.
I swear he said I was going to say he was going to say that I was the cool chick. He didn't. All right, so thank you all for being here. I really was like, I'm the closer. I had told Dr. Peacock there's going to be like 3 people here. And it was, the last time I spoke at this conference, I was also on Sunday, but I wasn't last. And so we'll say last, but definitely not least. So we've just spent the past hour talking about excuse me, this weather's killing me. We spent the past hour talking about dementia and delirium, and hopefully part of this hour will teach us how to keep patients from getting there. So this slide was for Dr. Moore. So I actually really want this t-shirt because that is literally me. And so part of the reason I agree to do any of these presentations is that I want to do a deep rabbit hole dive into a topic that is really interesting to me. And so being in the endurance sports world, you hear all sorts of, people who probably shouldn't be giving advice on social media giving advice and what you should do as you age and what exercise should look like. And so I was like, well, all right. So let's actually look at this from a clinical perspective and see what those recommendations are. So y'all can read the objectives. So I love Slido. All of my students know that it's way more fun to participate in a lecture than to just sit there and stare at it. So you can participate in 2 ways. Now I'm going to ask you any sort of hard questions. These are super easy. So you can go to slido.com and put that number in, and any of the Slido slides will have that number in, or you can use your phone and you can scan the QR code, or you can just put your hand up, because most of my questions are yes or no. And so, yes. It's the Wi-Fi's not. Okay, so if I would recommend being on the Wi-Fi, because I know that there's no code, that cell service is sparse in this room. So aging and physical activity. So we'll start with I don't want to say the bad and then talk about the good, but this is the reality. So 20 to 30% of older adults, and I'm going to say over 50, so all of the studies, we'll talk about this in a second, have various ages they use. But 20 to 30% of older adults in the US are physically inactive. So it's the rate of inactivity is higher in those with chronic disease and in racial and ethnic minorities and in low socioeconomic status groups. And that's a bit of conventional wisdom. So that's something that we need to think about. Inactivity, and I believe that, and I can't remember which speaker mentioned it on Friday afternoon, but our environment is one that promotes inactivity. But inactivity is a significant contributor to cardiovascular as well as metabolic disease. And you all know that I love and could talk all day about diabetes. However, the environment that we live in promotes metabolic disease and cardiovascular disease. Inactivity is on par with other major risk factors like smoking, excessive alcohol take, and obesity. There's increased risk of cognitive impairment later in life in patients who are inactive or people who are inactive. So I'm going to include all of us in this bubble here. So there's an increased risk of osteoporosis in both men and women, but more so in women with inactivity. Loss of muscle mass leads to weakness, so that kind of goes together. And we can have an onset of frailty at an early stage. So what is frailty? So we didn't really talk about that so much in the last hour, but it's part of cognitive decline. So there's a compounding effect of multiple comorbid medical conditions. So it's physical inactivity, serious muscle weakness, possibly cognitive decline, deconditioning, low muscle tone, and diminished functional capacity that leads to poor health outcomes. And so if we start here and we end here, when we think of frailty, we think of people who are advanced elderly. But really, as we'll talk about in some of our other slides, some of this is really related to physical capacity and not physical age. So let's talk about the prevalence of extreme sports for older. And by extreme sports, I'm not talking about like skydiving, though that has increased. I'm talking about things other than like walking on a flat trail or easy cycling on the Greenway. I'm talking about like marathons and Ironman and things that require significant physical conditioning as well as significant physical output when we're doing a race, right? So how is this increasing and why? So there's a 6% increase in registration for long running races like marathons in age groups over 55. In terms of triathlon, it's like quadrupled since 2012 in terms of people who are over age 60 registering for these races. So if we think about it, it just kind of makes sense. So prior to Gen X, we didn't necessarily have all of the organized sports that we do. And we all grew up, those of us who are, you know, like 40 to 60 probably grew up playing, or 55, grew up playing an organized sport of some kind. And so when you grow up playing an organized sport, as you age, especially as you get closer to retirement and either want to get healthier or don't have anything to do with yourself, you're going to go back to playing sports because that's what you know. The other thing to think about is Title IX. And so before that, like, there weren't really women's sports in school. And there were only a few men's sports in school. And now we have all sorts of sports in school. I think in terms of our undergraduate athletes, we have every sport except football, I think. We have, 500 athletes, undergraduate athletes? So everybody's playing everything. And so, you know, the other thing is, and we talk about this in triathlon, is active sports and hobbies are expensive and they're time consuming. And so, like, I can't keep up with people who are retired and train for 3 hours a day because they have the time to do it. They also have the money to buy the $10,000 bike. And so that all, you know, kind of rolls into the fact that we have people doing kind of crazy things that they weren't doing before. So here's our first Slido. So this is the question that gets asked by the CDC. If you get a phone call from the CDC, this is what they're going to ask you. So during the past month, other than your regular job, did you participate in any physical activities or exercises such as running, calisthenics, golf, gardening, or walking for exercise? Now, that's super broad. So like anything besides sitting on your butt at your desk or, you know, like walking from here to there, if you're thinking about those of us in healthcare, especially in the hospital. So most of us say yes, which means that, or at least most people answering the question say yes. So we're doing better than most of the population. So we said we were 7% inactive, which means that we're actually doing better than like Colorado, which is like physically impossible. Just like on the slide that they had the other day where they were like the least obese, they're also the most active. And so this is our self-reported physical inactivity. But what I want you all to look at here in terms of our population that we take care of is that the Southeast and Appalachia is at some of the highest end. So 25 to 30 and above percent of adults are inactive or self-reportedly inactive. So let's talk about some definitions in terms of, when we're saying older adult, what do we mean? Well, the ages vary by study, like I mentioned earlier, usually 60 plus, moving towards more emphasis, like I said, on physiology versus chronology. So you can be chronologically older and physiologically young. And I think anyone who wears a smartwatch can look up their, physiologic age based on, your resting heart rate and your heart rate variability and all of that stuff. So the ACSM uses 50 to 64 with clinically significant conditions as an older adult, otherwise 65 plus. What is exercise training? So that's not just going for a walk every once in a while. That's planned and structured intervention with the objective of getting better. So if we're training, it doesn't have to be for a race, but training in general in a planned way that has planned exercise parameters a couple of times a week. Low intensity, so when we say RPE, we mean rate of perceived exertion. So low intensity is using 20 to 40% of your functional capacity. Moderate intensity is where we think most of us would be when we're doing usual aerobic exercise, so that's 5 to 6. And if you look at the chart, moderate activity is breathing heavily, you can hold a conversation, you can't sing, you're still somewhat comfortable, but it's becoming noticeably more challenging. And so this is, for endurance athletes, this is where they live for most of a race. If you're doing a 5K, you're at more of a vigorous intensity. 7 to 8 rate of perceived exertion, greater than 60% of functional capacity. So this is borderline uncomfortable. I'd say for me this is uncomfortable. There's no borderline about it. You're short of breath, but you can speak a sentence. So this is, I think most of us when we're hiking up a really steep hill, okay, that would be like 7 to 8. And then we get above that, and we don't really have that in our research that we'll talk about today, but this would be like trying to mountain bike anywhere in East Tennessee, where you gonna die as you get to the top of the hill. So that's very hard and max effort activity. That's when you get there and you're on the bike and you're like, I'm gonna tip over because you're not going fast enough to continue rolling. So in the last month, what was your max perceived rate of perceived exertion on any one occasion? This is just a curiosity for me. I'm not answering, but I'm gonna say a 10. So most of us would say 4 to 6. I would say, so if you said 9 or 10, what were you doing? Oh, Lord, yeah, you're right with me. I was mountain biking in Farragut at Concord Park, which is a whole lot of fun, but they have these short little steep hills. Shoo, you get to the top and you're like a little dizzy and all that, and we'll talk about that in a minute. But most of us are at 4 to 6 most of the time, which is good. So what about these bonuses? So we've talked about the bad things that can happen when we don't do any sort of activity, but regular moderate physical activity, so like we talked about in that 4 to 6 range, 3 to 5 days a week, at least 150 minutes total each week. So for any of the upcoming second year students, remember that 150 minutes, it's an ADA thing, we'll talk about that in the spring. We have decreased disease incidence, like all of the cardiovascular and metabolic diseases. So, obesity and type 2 diabetes are cardiovascular diseases just as much as cardiovascular disease is. There's also a decreased incidence of certain cancers like colon and breast. As we get older, decreased risk of falls, dementia, and disability. And then there's those things that are hard to mention, like improved quality of life. And most of the studies that we have are in the older adult population in terms of this, as well as this sense of well-being. So lots of sport happens in groups. And this is super important as our patients age, because that keeps them from being in this isolated state in their house by themselves. Even if they just go to an exercise class once a week, they're spending time with other people outside of what they usually do. So there's, and I love this statistic, a 20 to 50% decrease in all-cause mortality with increasing physical activity volume. And so this was in a 12-week cardiac rehab program. Decreased mortality was 30% for the least fit. So we can still, it's the biggest improvements are for those who start from zero. And there's a dose-dependent response. So the most active get the most gains. So the longitudinal studies show substantial life expectancy gains, especially for moderate to vigorous intensity, fairly moderate volume over a long period of time. And we'll talk about some of the exceptions to that in a little bit. Because you all know I love physiology, if you've heard me speak before. So in terms of physiologic benefits, so why does it happen? So immediately following activity and for a sustained time after that, we have reductions in blood pressure because we improve our vagal tone. There's improved cardiac autonomic balance because of that improved vagal tone, an increase in stroke volume, so our heart becomes more efficient because it has to be when we're exercising, lower resting and submaximal heart rate as our body adjusts to what it needs, improved glucose tolerance and insulin sensitivity. So we've talked in diabetes lectures before about AMP kinase, and anyone who thinks about pharmacology knows that metformin can stimulate the AMP kinase pathway, but AMP kinase is our signal of energy need in our periphery. And so just exercising can decrease insulin resistance by upregulating AMP kinase. Overall, we have a catabolic response with moderate to vigorous intensity activity. And this is just another way to look at it. So I love slides that have a chart with everything on it. And so the American College of Cardiology article that I used has this beautiful slide that has all of the things that regular physical activity can benefit. So we're going to move from physical activity to mobility. So can you touch your toes from a standing or V-sit position? Okay, so we're going to do we're going to show hands. Can you do it? Yes. Can you not? Okay. So why is that important? So we don't just recommend physical activity anymore. We recommend strength, mobility, and balance training. And so for those of us who grew up doing aerobics, strength training is great, but it makes our hair stand on end because we're like, how am I going to fit that into everything else that I do? But it's really, really, really important because it brings us to this comprehensive approach to improving overall function and not just cardiorespiratory fitness, which is what we're getting with our endurance activity or with our jog or with our recumbent bike activity at the gym or any of those things. So programs that integrate balance, strength, endurance, gait, and general physical function training show up to a 23% reduction in falls and fall-related injuries, especially in older adults. So it's really important to build the muscles that we need to use while we're building our cardiorespiratory function. So resistance training preserves muscle strength and overall physical function. So it is just a fact that as we age, we lose muscle strength. Just a thing. Can we get it all back? No. Do we need to look like a bodybuilder? No. But do we need to be able to get in and out of the car and up and down the stairs as we age? Yes. So mobility and flexibility programs can also improve quality of life measures because you feel better about the world when you can get on and off the couch without like needing to grab onto somebody else in order to do it. Neuromuscular and balance training. So these multimodal exercise programs reduce the risk of falls in older adults, but increases in independence over time. So if we're not falling, we're not breaking things, and we're able to maintain our independence in our home or apartment or what have you over time. And so Tai Chi is proven. We can all go do Tai Chi in the park, like the stock photos. Some of the stock photos were great. the same poor guy was injured in like 6 different photos in different ways. But Tai Chi and balance training have positive effects also on psychological well-being. And my conventional wisdom thought, just like what I said a second ago, is that it really makes us feel good to know that we can do the things we need to do and keep doing them. So now we're going to talk about some of these risks. So I mentioned when I started that there's comments on social media and physicians giving advice to patients, including cardiologists, and like, why are you doing this? You need to be sitting on the couch, and nobody need to be sitting on the couch. Like, unless you physically cannot walk, you don't need to be sitting on the couch, and you can do something in a chair if you can't walk. But do you personally, or within like 1 or 2 degrees of separation, know somebody who has experienced a sport-related sudden cardiac arrest? That's what SRSCA stands for. So any kind of sudden cardiac arrest associated with a sport. And this, I think this knowledge is what our N of 1 studies of horrible things happening change our judgment. And so I mean, of course, because I live in this community, I've known of a few people, right? And mostly men, mostly over the age of 55, but I've known of 2. And so then that leads people to say, like, this is definitely not safe for folks who are older. These exercise activities are not good. But let's talk about these risks. So risk of sudden cardiac arrest, it's a thing. So regardless of sport, 350,000 Americans suffer a sudden cardiac arrest annually. It's a pretty low survival rate. 5 to 6% of those are associated with sports activity for all ages. We are not going to talk about younger ages. So the data that I looked at was ages 35 and up. There's not a whole lot of studies in older patients, but we're getting there. So this first study that was published in Circulation in 2015 was for sudden cardiac arrest that was sport-related in ages 35 to 65. So 5% of the cardiac arrests occurred during sports activities, which goes with some of the other statistics. The mean age was in early 50s, so incidence is super low, 21.7 per million per year, really low. Not to say that it doesn't happen, but really low. But the relative risk is super high for men compared to all other causes of sudden cardiac arrest. So men in intense sports-related activities. So 16% of those who had a sports-related sudden cardiac arrest had cardiac disease. Over 50% had 1 or more cardiovascular risk factors. 36% had typical cardiovascular symptoms in the week prior. But 43% had no risk factors whatsoever. And in some of the data that I looked at, and I can't remember whether I put that in here, most of these events were in people who were very new to sport, so had just recently started their exercise programs. So RACER registry data, so this is in runners. This was published in 2012. So they took data in over 2 decades from people running marathons. And so the longer the race, the more likely the event. And events increased during the 2nd decade of the study, especially in men. And the question that they had that has really borne out by some of the statistics we've already mentioned is that are individuals with higher baseline risk who just want to get fit taking on, endurance sports and then thereby kind of shifting this risk base. So the study published that I've taken a lot of my figures from the American College of Cardiology Electrophysiology Journal was published in 2023, so super recent data using a similar database as the one that I made for people 35 to 65. So 2% of sudden cardiac arrests were related to sports. So this actually decreases with age. So the more likely population is that mid-40s to mid-50s. So 2% are related to physical activity not considered sports. So they didn't consider things like gardening sports. And I have to tell you that like there were a bunch that occurred during sexual activity and they didn't consider that sports either. But you have to think of things that are going to suddenly bring the heart rate up as well as bringing catecholamines up. More common in men to age 80, more common in women after, but more common in the younger ages, over 65. So even though they had a sudden cardiac arrest, if it was sports related, typically there was a lower burden of risk factors. So what do we do with all this? So overall relative risk of sudden cardiac death during and after vigorous activity is only 1 in 1.5 million episodes. And it's significantly lower for women. So we're in way better shape. Our likelihood to drop dead from a cardiac event unless we have a significant risk factor is pretty low. Per the data, in men, especially younger, hypertrophic cardiomyopathy is still the biggest reason, whether it's diagnosed or not, especially if there's more than one other risk factor. In women, more likely to have coronary anomalies, very uncommon cardiomyopathies, and long QT syndrome. The relative risk of acute cardiac events during vigorous increases with the level of exercise. So it increases with vigorous to high intensity and not just moderate intensity. So why? Because cardiac demand increases. And something I want you to think about in looking at your patients is look at your actual patient, because cardiac demand is determined by metabolic demand related to their functional capacity. So those METs that they need that we talked about earlier to do like regular things, so it may take them more METs to walk to the mailbox than it would take you or I to walk to the mailbox. So that might be a vigorous intensity activity for someone who's inactive with a whole lot of risk factors. So your assessment of risk is individualized. The highest risk of acute MI, sudden cardiac arrest, sudden cardiac death is during or in the hour after activity. So that's why towards the end of longer races, the risk increases. So if we're talking about like a marathon or a half marathon, or so just for reference, a marathon is 26.2 miles of running. I'm not a runner, sorry, sorry Dana. I set my top limit at half marathon. So half marathon is 13.1. When we talk about triathlon, we get into much bigger distances. So a full Ironman is around 144 total miles. So you've done a 2-mile swim, 100-something mile bike, 112, and then a marathon. And so that's a lot of activity. And like I said, most of the time in those races, you're in that moderate to almost vigorous component. Increased vagal tone in the hour following the vigorous exercise is really a lot of what increases that risk, because it doesn't allow the heart to recover. So there's an increased risk for Brugada syndrome or ventricular arrhythmias, especially in long QT syndrome. Oftentimes, when we look at these patients, they have non-acute coronary artery disease. It was something that they mentioned the other day. So the coronary calcium, so they've got calcified plaques, but not those plaques that cause heart attacks. But what they do is decrease cardiac function while we're exercising. So that's more common as exercise-induced myocardial ischemia than acute plaque disruption. So what we think about as a typical MI is not what's happening here most likely. So, but why? So the tachycardia exhausts our vasodilatory reserve beyond that spot where there's the stenosis. So we've got a stable plaque, but we can't change the size of the blood vessel to make sure that we get enough flow beyond that. When we discontinue activity, it can make that ischemia worse because we have less venous return, so we're not pushing it through anymore. We've stopped. Any of you who have stopped exercising and felt like passing out because your heart rate goes, zoop, think about what's happening to the coronary arteries. So this is why it can be common in that hour following activity. Other things that we don't have time to really go into today are electrolyte imbalance, heat disorders, and the excess catecholamines. If we had time, we would talk about a lot of what happens with the excess catecholamines, and definitely heat disorders. And so if you see lots of athletes, you'll get into that sort of discussion with them. But for right now, we just want to figure out how do we reduce these events, because the risk of these events is low, but it will prevent some people from thinking they should be exercising. And it really changes the way that we look at advising patients. So how do we reduce these cardiac events? Really not something that we can do so much, but we can educate coaches and athletes of warning signs. And those being syncope, lightheadedness, perceived palpitations or arrhythmias. If any of you know an endurance athlete, trying to tell them to stop when this is happening is like trying to tip a cow. So good luck. But we want to have people understand what the warning signs of decreased perfusion are, so that they can back up before they have any sort of event. So emergency drills for race directors and coaches, training in CPR, and use of an AED. Having the mobile AEDs is a whole lot more common at races. The problem is for some of these endurance races is how do you get it to where it needs to be at the time that it needs to be there? Stressing the importance of bystander CPR. And so this is just my recommendation. So I have no data on this, but to me, if your patient's coming to you and you're recommending exercise, and they are of any age, really, and they're going to participate in any of these races, have them learn how to do CPR. Like, it's super easy, fairly inexpensive, and I mean, it would definitely benefit someone who has an event to have someone who's running next to them know what to do. Because survivability of sports-related sudden cardiac events is significantly higher because they're usually witnessed and somebody is there to help out. Whereas, you know, if we have it at home and we're the only person that's there, there's nothing that can be done. So what about cardiac maladaptation at the extreme? So we can get to that point, and this is not our average patients, you know, but our typical cardiac changes with long-term training is enlargement of all the cardiac chambers, which we want to happen, improvement of function and compliance, and electrical remodeling. So many endurance athletes have sinus bradycardia and walk around with heart rates that would make most people feel a little bit lightheaded. But that's normal. That's normal what our heart is supposed to do. But we're hearing more evidence that there's like a max benefit. So there's high volume, high intensity training over time. So we're talking over 20 years of high volume, high intensity training. Increases risk of AFib, increased coronary artery calcium, and myocardial fibrosis. So eventually the adaptation becomes a maladaptation. So the risk of AFib is 2 to 10 times higher in endurance athletes than in controls because there's a left ventricular remodeling plateau. Now this is, I mean, most people are not in this category, but just thinking about the fact that like our absolute extreme athletes need counseling, that this is a risk, especially men. So what about myocardial fibrosis? Because that really only happens in pretty significant heart failure. So we have collagen infiltration, then this is just at baseline, what is fibrosis, and the extracellular matrix that develops after an injury, so whatever that injury happens to be. So how do we figure it out? Cardiac MRI. So LGE is late gadolinium enhancement. So gadolinium enhancement that happens after we would think to see it. So competitive endurance athletes have a higher prevalence than controls that just do usual exercise. So why are we talking about this? Because I think it's cool. But because as our older population shifts to thinking, you know, Ironman at 75 is a good idea, not to say that it's not, but it's something to think about as we're counseling with risk, that there's possibly a loss of health benefits as we get to the extreme side of vigorous intensity exercise over time. I had to throw in pickleball. Had to. So though Dr. Moore thought that I was going to talk all about musculoskeletal injury because I need bubble wrap, this is my only slide. So sport-specific risk of injury is fairly high. It really is, and I guess I'm the poster child for that, even though I just turned 50 a few months ago. So 249 injuries per 1,000 hours of exposures. That's a lot of injuries, right? So physical therapy is in good shape for like forevermore because our population is aging. Most of these injuries are sprain, strain, fracture of the fibula is most common, shoulder and knee injuries, mostly because we're probably not training to do the sport that we're doing, and that we're not building those muscles that we need to build to decrease our risk of injury, or you just have really bad luck. I'm sticking with that one. Over the past 10 to 15 years, we've had a significant increase in injuries because people who are older are doing more sports. Not picking on pickleball, but both total number and incidence. So the projected increase is 100% over what it's already been increased by 2040. Because more people are getting injured more frequently because people who are older and probably less, I don't want to say less fit because it's not so much fitness as it is muscular stability. So patients over 65 or people over 65 are 6 times more likely to be severely injured cycling than 25 to 44. I'm screwed. Because except one, all of my injuries have been cycling, one bike or another. So what is risk mitigation and safety practices? So safety equipment, it makes my hair turn back to reddish brown when I see people on a bicycle without a helmet. Like, brains are important. Please, wear the helmet. And the one time you're going to fall on your mountain bike is when you don't have your pads on and they're keeping your car warm. And so, not that I know that from experience. And so using the safety equipment that's available to you and not really caring that you look ridiculous. Learn to do the movements correctly. So picking up a sport, pretty much over the age of 40, it's a good idea to take some lessons, to go slow, to ease into it, to learn what you're doing before it's like not couch to marathon in 5 weeks. Okay, we can't do that. Definitely can't do that over 40. Repetitive use is common. Those are some of the most common injuries, so making sure that people understand that these are risk factors. And choosing lower impact. And so things like cycling and swimming, and impact is important for prevention of osteoporosis. We can get that from walking, so we don't have to do super high impact activities, but lower impact activities have lower risk. So what about that exercise prescription? So here we go. So the ACSM guidelines, and I know these are tiny, hopefully they look better if you have it on a computer screen. So there's 4 things to think about. The current level of physical activity, and these are their newer guidelines. They came out around 2015, 2016. Any known cardiovascular, metabolic, or renal disease, any signs suggested of cardiovascular disease, so any symptoms or signs. And their desired or anticipated exercise intensity. So do they want to go from 0 to marathon in 6 weeks? So where do they plan on going? So this requires asking that question, not just what do you want to do, but what's your goal? Like where do you want to go with this? And so the chart here that came from the ACSM guidelines can give you an idea of what active means, but we've already talked about most of this. The one thing I do want to mention is signs and symptoms. So any pain or discomfort at rest in the chest, neck, jaw, or arms, or anything that could point to possible myocardial ischemia. Unusual shortness of breath, so shortness of breath that's different from what they have usually. I guess that's what makes it unusual. Lightheadedness, when they're not expecting it. So if they usually get lightheaded when they stand up from a seated position, we probably need to look into that. But lightheadedness that is different from anything they would usually have. Any ankle swelling, that's different from usual. Awareness of a rapid or a regular heartbeat, or burning or cramping sensations in the lower extremities, so basically symptoms of claudication. So this exercise, the physical activity vital sign, I've snipped some of it here, but the link allows you to put in the numbers on the PDF. So the same kind of question that we asked earlier, how many days per week do you engage in moderate to strenuous activity? On average, how many minutes do you do it at this level? Multiply it. And then there's an optional question of how many days a week do you perform muscle strengthening exercise, such as body weight exercises or resistance training. And so good way to figure out their level of physical activity. So that takes away number one, presence of signs and symptoms. Any symptoms warrant evaluation. So any symptoms of possible cardiovascular disease warrant evaluation. Known cardiovascular, metabolic, or renal disease. They must be asymptomatic to begin an exercise program, and it really depends on their current level. Everybody, I don't care what you have, needs to be asymptomatic in order to start an exercise program. So they have this great algorithm. Unfortunately, the only way to get this is to buy their book, but now you have it because I bought their book. So for folks who don't participate in regular exercise, that are asymptomatic with their known cardiovascular disease, need clearance. If they don't have any cardiovascular or metabolic disease, then they don't need clearance for light to moderate activity. And they gradually progress to vigorous activity. But the moral of the story here is that for people who are inactive, if they have any sort of symptoms or they have known metabolic disease, that they need to be evaluated. Now, the problem with that is what is evaluation? And that varies depending on which sources you look at. So what about those who participate in regular exercise? So it's really depending on what they're wanting to get out of it. Like, where are they wanting to go? Are they wanting to do vigorous activity? Like, are they wanting to, do a mountain bike race? I mean, is that where they want to go? And that really makes us decide whether or not they need to be evaluated. So we have, and this is our thought. We have a 55-year-old male with stable hypertension with a current exercise program of walking 3 miles 3 times a week. He wants to join a pickleball group at the Y. He has no symptoms of cardiovascular disease. Does he need exercise testing? And I have this set to go ahead on click, so I'm gonna make you all answer it first. So the students know with Slido that as soon as people can see everybody else's answers, they change their answers. So I say no, this patient does not need cardiovascular testing. But what do we recommend? We say, you know what? You're going to need to increase gradually. So maybe continue your walking program and, make sure you take a pickleball class before you start playing pickleball if you don't know how to play it. Make sure you add in some strength training because you're going to be doing lots of lateral movement. And what about balance training? Because that's going to decrease your risk of injury. So when do we do screening exercise testing? So we consider these asymptomatic patients, consider exercise testing in these asymptomatic patients. Anybody who's high risk, particularly inactive men with diabetes, and especially if they want to try to pursue a high-intensity endurance sport. Somebody who's habitually sedentary with multiple risk factors, who want to start a vigorous exercise plan. And I love this one. This one was really in an article, clinical suspicion of inaccurate history or symptomatology. So they're lying to you. If you suspect that they're not telling you the truth about their symptoms so that, they were that one, in terms of clearing them for return to sport, this is the one who tells you that they're not having headaches when they've had a bad concussion last week. So make sure that if you have suspicion, you recommend testing. So the reason these recommendations have changed, they've become much less stringent is because exercise is really beneficial. It's super important. And the more we stand in the way of people exercising, the less they're likely that they are going to do it, especially as they continue to get older. A self-guided pre-participation testing questionnaire is the PAR-Q Plus, and patients can do this. You can put it into your portal that they can do it when they get there. They can do a paper version. It's really gives you an idea of whether they need testing. Personal trainers use it, gyms use it to see whether people should really be exercising. So if we have mandatory screening for everybody that is over a certain age, it's really going to keep people from exercising because nobody wants to do that. So how do we recommend people move on? Like, how do we do this? Because most of us are not sports med trained exercise professionals, including myself. And so what's the best way to go about it? So if we use the FITT-VP or FIT-VP framework, it really helps us to figure out, what do I tell patients for an exercise prescription? So I've given you two sets of recommendations here. I took the World Health Organization ones out because it was just too much on one page, but they're all very similar. And so we have frequency, intensity, time, and type. And this is going to differ for all patients. So maybe this is someone who's completely inactive, that's been inactive for 20, 30 years. And so we might say they need to walk back and forth to the mailbox for 20 minutes 3 times a week, provided they, don't have one of those crazy steep driveways. And that might be their aerobic activity, where it's going to change for somebody who has a higher level of baseline activity. In terms of intensity, we're going to recommend to start low and go slow, because the biggest risk for that sudden cardiac arrest is in inactive people who go from 0 to vigorous. It's hugely stressful for the cardiovascular system. So even though they're a former athlete that wants to keep up with everybody else, but they've been inactive for a few years, really, really, really encourage them to start low and go slow. And they may realize how bad they feel when they do vigorous intensity activity when they haven't been. But that's how we recommend we slowly increase in activity. Time really depends on your patient. 30 to 60 minutes a day is great. A couple times a week, some people don't have the time for that. So asking them what they really can do to make them feel successful and then go up from there is really going to be helpful. In terms of type, what do they have access to? So the other thing is joining a gym is expensive. I mean, running shoes are expensive, but they don't have to buy the $300 running shoes in order to go for walks in the park. And so walking is a great place to start. As well as, body weight activities are also really easy. And if they have access, if your patient has access and knowledge of the internet, they can find YouTube videos to watch and how to do this stuff. They can do it at home. Nobody's watching them. They don't have to be embarrassed. So really, this is looking at the big picture. Skill development and endurance takes time. Pain doesn't equal gain. So a lot of us grew up in the harder you push, the better you're going to be. That's not the prevailing thought. Even in younger athletes now, it's definitely not the prevailing thought in older athletes. And so taking the time to learn the sport, taking the time to get conditioned, really important. Nutrition and hydration are like the companion to exercise. So if your patient's going out for a run and they're like, I don't need any water. Yeah, you do. So you need water, you need nutrition, there's all of these supplements. You don't necessarily need supplements, but you may need some extra salt depending on how much you sweat. And that's a conversation that they need to have with us, because if they go and spend half the day drinking Element in their water, that's a whole lot of salt for someone who might have hypertension. We don't have time to go into all of that today, but make sure that they focus on hydration and fueling for endurance sports. So anything beyond 60 to 90 minutes needs carbs. And even depending on your patient, something above 45 minutes that's intense probably needs carbs, or they're going to bonk and feel like garbage halfway through their workout. Strength training and recovery, active recovery days, like going for that nice slow walk when you had a hard bike ride yesterday, is very important to get the body to recover and to do what it needs to do. So, weekend warrior syndrome is a thing, yes or no? It is, I mean, I know that only a few of you answer, but it is absolutely a thing. I love this picture. Engaging in demanding recreational sporting activity as on weekends, despite minimal activity during the week, is the definition of weekend warrior. The typical population is men ages 40 to 55. Common source of musculoskeletal injury due to lack of conditioning. We already talked about why all this happens. There's an increased risk of sport-related sudden cardiac activity depending on sex and age. More common in men in their 40s to mid-50s, or with risk factors. Try to advise your patient to be realistic about the expectations of being able to perform highly once a week without doing anything else throughout the week. Warm up and listen to injury cues before injuries happen. Pain doesn't equal gain. We've said that before. And just because you can doesn't mean you should. And, you know, just because you can go out and bike 40 miles and pay for it for the next 2 weeks doesn't mean that you need to be doing that. And lastly, recommendations for the frail elderly. So these are like way over here, so what do? We can use this SARC-F screening, which I have on the screen here, the frail scale that gives us an idea of where they are. But suffice it to say that any activity is beneficial in any population. So even in the frail elderly, any form of activity is better than no activity. So whether that's chair exercises, hand grip strength, et cetera, et cetera, et cetera. Because any level of activity can improve function over time and get them even out of that frail scenario. So questions?
So as far as financial barriers, have you or has anyone else in this room like found a way to get insurance to, I know some insurance companies will pay for gym memberships, but what about yoga classes or the Tai Chi classes or something like that? And with the frail elderly, you know, I'm wondering, could we send them to PT even to learn these chair exercises and stuff? Like, have you guys found good ways to get those covered by insurance?
That's probably more of a question for you all because I don't do outpatient practice anymore, but my guess is community services, like Silver Sneakers, things like that, looking for places that take Silver Sneakers is going to be helpful. PT and the frail elderly is going to be your gateway to exercises, but even having family members look stuff up online, getting them some exercise bands, you can buy all this stuff at TJ Maxx. And so it's not expensive. You know, and that can be done in a chair, right? Other questions? Well, we have got folks in the back that have papers to pass out and collect for your evaluation. So thank you all for staying till the bitter end. If you want to look at a resource, the one that I have highlighted is going to give you I think the best information, that and buying the ACSM book. You're welcome.
If you're on LMU-live.com, there should be a link at the top that says downloads. If you go to that, the first two links are going to be the attestation forms. So you're going to want to fill out the one that's appropriate to you. There's one for DOs, there's one for all other professions. You will fill that out on your computer at home. You will save it and email it to me, or you can even take a picture of it and email or text that picture to me. You should have all my contact information in the emails I've been sending over the last few days. Okay, do all the osteopathic physicians in the room have their form? Okay. Everyone else, if you'll raise your hand, Ms. Engel is going to bring you the appropriate form. We would also ask that you make sure to turn in your program evaluation to us. We take what you say on those evaluations very seriously, and we actually build the conference schedule each year based on recommendations from the previous year's attendees. While I'm here, are there any questions from any of the audience, in person, online, about the CME attestation process? Everybody inside the classroom get an attestation form of some kind. Yes, ma'am. Yes, so if you have done a mix, if you've been with us in person, but you have also watched some of the sessions online, that is still attending the CME session, so you would check that you attended that session. A reminder that the OMT sessions that are listed on the form were only available in person. So if you're part of the online audience, be careful not to go through and check everything because you will not be checking those OMT boxes. And I'll just give a reminder that our conference is the second weekend of June annually. Next year we'll be at the Gatlinburg Convention Center. We hope you will join us for that, and thank you all for spending the weekend with us again. Join us for that, and thank you all for spending the weekend with us again.